And so now it's my honor to introduce Dr. Baxter, Dr. Richard Baxter, DMD, MS. Dr. Baxter is the founder of the Alabama Tongue-Tie Center and Shelby Pediatric Dentistry in Pelham, Alabama. He is an internationally recognized speaker on tongue ties, an instructor of the acclaimed Tongue-Tied Academy course, and the author of the best-selling book, Tongue-Tied. He is a board-certified pediatric dentist and a fellow of the American Academy of Pediatric Dentistry. Dr. Baxter is an honorary member of the American Laser Study Club and the recipient of the 2021 Kumar Patel Prize in Laser Surgery. He's a light scalpel user and has been a keynote speaker at the Breathe and Thrive ALSC Symposium since 2019. He attended the University of Alabama at Birmingham School of Dentistry, graduating at the top of his class. Dr. Baxter received his pediatric dentistry specialty certification from the Nationwide Children's Hospital residency program in Columbus, Ohio. And please help me in welcoming Dr. Baxter.
Okay, awesome. Thank you, Daniel. Appreciate it so much. It is great to see everyone tonight virtually. There's about 225 of us on here, and maybe we'll get some more even. A few disclosures. As Daniel said, I am the owner of the Alabama Tongue-Tie Center in Birmingham. Did write the book Tongue-Tied. We have an advanced live patient course, which used to be once a month. Now is like every week I'm home. And then we also have the Tongue-Tied Academy online course, as well as an update coming soon. But the important part is I have no interest or any dental or laser companies. I'm not paid by Light Scalpel. I don't care if you buy a Light Scalpel. I think it works well, but this is not sponsored by them. This is sponsored by American Laser Study Club, but this is a free webinar. I'm just doing this for fun. So anyway, glad you guys are here. A few translations of the book if you speak a language other than English. So we have Spanish, French, Polish, Danish, and Chinese, Sheshidai. And a few new ones coming in 2024, Tongue-Tied, which is Korean. Probably said that wrong. Zungenband, which is German, and then Lingua Legata, which is Italian, and then Lingua Presa, which is in Portuguese, coming soon. Italian, I almost have the file for, probably the next few weeks. I'm hoping we'll get that up before ICAP even, so we'll have an Italian version in hand. Tongue-Tied Academy is my COVID project. It's 25 hours, the most comprehensive tongue-tie course available. And we also have an update now, which is going to be at least 13 or 14 hours. We're currently going through it. He's editing it, getting the website up and running. So hopefully have this up in about a month or so. So keep an eye out for the update as well. We'll post it on all the social channels. So at our advanced live patient course, it's as hands-on as you can get without having a dental license in this state. We train up to 4 doctors at a time on tongue-tie releases. We do them on Fridays, and we have a lot of fun and eat good guacamole. If you like guacamole, come see us. And then, of course, as I mentioned, we do donate all the money to charities. So we have a couple of health centers in Nepal and the Himalayas, lots of water projects throughout South Asia, Sub-Saharan Africa, Southeast Asia, and then some human trafficking projects as well in the Himalayas, as well as locally here in Birmingham, Alabama. So sponsor a bunch of kids. It's a joy and a privilege to be able to give back in this way. So I'm not doing this just to get rich or make more money. It's really to help people thrive in their offices, help their patients thrive, and then also to help people around the world thrive. So that's our goal. And here's my family. So there's Hannah and Noelle, our twin girls that got me in this mess in the first place on tongue ties. And then, of course, Molly. Molly's 5 and the twins are 10 tonight. Or sorry, they're 9 and 3/4. They'll be 10 in just like a month. So they're like almost 10. And then there's my wife, Tara. Went on a Disney cruise a few weeks ago. It was a lot of fun. We've never been before, so it was our first cruise, but it was a lot of fun. And Tara stays home and homeschools the girls, but she's a nurse practitioner by trade. And so we're going to talk about today is nothing like earth-shattering. It's really just simple like medical or dental model, right? You need to get a good history of the patient. Sorry, I'll back up a little bit. Do you guys know what this is right here? You guys heard me talk before, probably knows what this is, but most patients, they don't come see us saying, hey, can you laser my baby, right? They're thinking like, oh my gosh, like my baby's not eating right, or my child's not speaking well, or not sleeping well, whatever the case is, right? We're not thriving. And so they're on the struggle bus. And so to get them from the struggle bus to thriving, we have to follow the yellow brick road, right? And so history, we need a good history in order to get there, a good examination, good diagnosis. Otherwise, we will veer off the path, right? And then we got to treat it properly. There's aftercare, and then there's follow-up. Those 6 things, if you leave any of one of those out, like if you don't treat it right, you skip the aftercare stretches, you skip the follow-up even, you could do all the other 5 things right, and they're not going to get to thriving as much as possible, right? We're going for as close to 100%. We know nothing's 100%, but getting close to 99%, 100% of the time is our goal, of course. So really what we need is a paradigm shift. So the old paradigm is like a problem-focused history. So if you go to, like, no offense, if there's like an ENT or pediatrician on here, I'm not sure if it's parents or lactation consultants, dentists, physicians. So I'm so glad you guys are here, whoever is here. But so the typical way dentists do this, pediatricians, neonatologists in the hospital, an ENT would do kind of like this. So it's like, hey, mom, what's going on today? Having some breastfeeding struggles. Let me take a quick look. They'll take a look maybe with a tongue depressor, maybe a glove. Then they'll offer a snip or a clip, which is often just like a partial clip, phrenotomy maybe. Then minimal to no stretches. They'll say stretches aren't needed. Follow up as needed. So just give us a call if you have any problems. And it's just that doctor typically, maybe a lactation consultant, maybe a speech therapist. But if you do a minimal history, a minimal exam, a minimal clip, minimal stretches, minimal follow-up, minimal team approach, you're probably going to get minimal results, right? And so this is the old paradigm, and this works really well for a toothache. So I did this yesterday, right? For a toothache. Hey, mom, what's going on today? The tooth's hurting him. Okay, when's it hurting? Is it waking him up at night, hot or cold? Let's take a look. We'll get the tooth out. There's no aftercare for a toothache, right? Just, don't suck on straws, don't spit hard. There's no real follow-up. Just call us if you need anything, right? And it works really well for a toothache. But when you apply that same paradigm to tongue tie treatment, it does not work as well. So really what we need is a new paradigm, and that includes a comprehensive history, a full exam, a full release of restricted tissue. And I'll show you how to do that in just 1 hour tonight, right? Stretches 3 times a day for babies, twice a day for kids, for 4 weeks is typically how long we see it taking. Follow-up mandated. Well, what if they're 4 hours away? Well, we can do a virtual follow-up, right? With a team approach. That means all the team members that are on the call tonight, you are part of the team, whether you're a parent or a provider, a doctor or a therapist, we're so glad you're here. And if you add all those things up, you're doing full exam, full history, full release, full stretches, follow-up team approach, you will likely get impressive results. So a few pearls, if you remember nothing else tonight, remember this. Always work with a team approach to care. All proper diagnoses start with a proper history. So misdiagnosis then comes from either not listening or not examining fully. So you want to listen to mom's story without interrupting. Empathize, of course. I've been there. I've had all 3 of my girls had it. I had one. I recently had it fixed. We review all the symptoms systematically, one by one, and we take notes. We examine properly. So often that includes gloves, tools like a mouth prop. And then here's the key. Symptoms and function are more important than the appearance. Sometimes it's to the tip and they have minimal symptoms, which still is probably worth releasing those if it's to the tip. But what's even more interesting is they're like maybe a quarter of the way there, just a little bit tight, and they have a mountain of symptoms. Those ones are also worth releasing. Those are the ones that sneak under the radar. People don't realize my kid has a tongue tie because no one told them and it's not to the tip. But they can cause just as many, if not more problems than a to the tip sometimes, right? It doesn't make any sense. It's like an inverse relationship. So we image all areas of concern. We take pictures, discuss findings, and then make a plan. And it might be for release that day. We always save time to do it the same day as the consult because a lot of our patients are coming from 2 to 4 or more hours away. And so we always save time, but it's not always releasing the same day, depending on that situation, right? So release fully and precisely if indicated or refer. So if you're watching this, you're a therapist, you're a physician that, I'm not going to treat these, but want to learn how to, identify it and how to refer. That's great. I'm glad you guys are here. High quality stretches are critical. Demonstrate them to parents as well. So we show the parents and then we have the parents do them back. And then follow up at 1 week minimum. So sometimes it's twice, sometimes it's 4 times to come back for a follow-up, right? Just as much as they need. So I'm not going to go through this whole form, but you can find it. I'll post a QR code in just a second that has all of our forms on it. You can download them. But basically, these are more tongue tie issues over here. These are more seal issues or lip tie and buccal tie issues over here. We'll talk about all that. We always want to ask how mom is doing. Every day we check the moms for postpartum depression. We have at least 1 or 2 moms score above a 10 We had someone score like a 13 yesterday, which means they're basically have postpartum depression. Above 10 puts you at a high risk on the EPDS-10. Down here is mom's symptoms, right? So if they're breastfeeding, they'll fill this bottom part out. If they're not breastfeeding, they'll just fill the top out. But notice that if they're not breastfeeding, the babies can still have all these problems. So switching to a bottle doesn't magically solve the problem. You say, well, these like babies are like milk leaks out all the time, or babies spit up. That's normal, right? Babies hiccup. Yeah, if they just had a couple of things on here, it's probably not a tongue tie. But if they come in and they have every check mark or 2/3 of them or a lot of them, right? That the degree of suspicion of there might be a tongue or lip tie, along with some other kind of issue, like there could be a neck tension, torticollis, there could be other things. If they've failed therapy and they're still not getting better, our degree of suspicion of a restricted tongue or lip increases, right? And so just because something is common, like gassy, and it's cute, it's funny, the baby's farting a lot, but it's not normal. They shouldn't be, right? Or colic's awful, but it's common, but it's not normal or optimal, right? They shouldn't be colicky. They shouldn't be spitting up every feeding, right? They worked hard to get that milk. They should keep it down. So we need to look at beyond the symptoms. And so what happens typically is the babies are spitting up and they're given some maybe some Zantac. Oh, sorry, Zantac causes cancer. They give them some Pepcid, right? And then that doesn't work. They give them some Nexium off-label, of course. And it can lead to bone fractures in the future, right? Or they're gassy, they're giving some gas drops. They're colicky, here's some gripe water. They can't, it hurts, here's a formula, here's a nipple shield. All these Band-Aids is what they're given. Instead, what we need to do is look deeper and look at the root cause. Why are we having these issues? So if it's not taken care of as a baby, it doesn't magically get better. That would be nice. That would be great if it just like got better over time, but it doesn't. So if you don't treat it as a baby, they can end up with speech issues. So speech delay, or they're shy, frustrated, then get embarrassed with their speech. It's really sad. They have like no confidence with their speech. Trouble swallowing. So solid feeding, they're slow and picky eating. They have a small appetite, trouble gaining weight, right? Poor growth and development. That could be from poor sleep quality or poor meals. Airway issues, so mouth breathing, poor oxygenation or snoring. Poor sleep quality leads to daytime symptoms as well. So like behavior, ADHD, stress and anxiety, aggressive behavior can happen from poor sleep quality. Often you notice they have teeth grinding, can affect their brain development. By the time the baby is, or the child is age 3, their brain is 80% the size of an adult brain. By the time they're 5, it's 90% the size of an adult brain. So what we need to do is identify these kids early, like early preschool. A baby is perfect. Like the first week of life, if they have it, is the best time to do it, right? But if not, I mean, 6 months old, 2 years old. Often people come to our office for the live course and they're like, I'll treat babies, I'll treat 6-year-olds that are cooperative and up, but I'm not going to do that preschool age, that 1-year-old, that 3-year-old. But those kids, oh, please consider treating those, right? We'll talk about that today a little bit too. And I'll show you how to do it without putting them to sleep. And really, it's possible because of laser technology. I'm not trying to sell lasers again, but you couldn't do this before with just scissors easily because of the bleeding. It'd just be pouring out blood when you do it. It has truly made it so much easier. Now we don't have to take these kids to the operating room and do it. We can do it in the office, right? With just some topical numbing jelly. And it's really well tolerated by the parents and the patients. So can cause issues with dental development, GI symptoms, reflux, and even constipation. I promise you it does. I wrote a blog post on it. If you type in tongue tie constipation, it pulls up. Don't have time to go into it now in just 1 hour, but it makes a difference. It's one of the most consistent findings we see is with constipation. So speech issues, trouble with all kinds of different sounds, speech delay, trouble speaking clearly or quickly, like I'm doing now. Again, I only have an hour, so that's why I'm talking fast, sorry. Stuttering, lisping, slurring words. We have some crazy videos of people with lifelong stutters improving after we released their not obvious tongue tie. It's in the Bible, Mark 7:35. His ears were opened, the string of his tongue was released, and he spoke plainly. I kid you not, it's in the Bible. It's in the Quran. It's in the earliest Japanese writings. King Louis XIII was tongue-tied, right? Solid feeding, they're gag on foods, they'll spit out foods, they'll swallow it whole, which can lead to constipation. They don't chew well. And if you don't chew your food right, it doesn't start the journey right, it won't end the journey right, right? It also puts them into more of like a rest and digest, parasympathetic. That's also why they have less constipation. The third reason is the swallow starts the peristaltic wave that travels down your GI tract. And that's why they often poop better, which is funny. Like babies up to adults even will have less constipation. Anyway, so we did have time to go over it, but they take forever. They're taking like an hour to eat, 45 minutes to eat. They graze on foods. Sleep and airway issues. Again, mouth breathing is common, but it's not normal. if you mouth breathe more than 35% of the time, so if a kid's mouth breathing all night, or if it's like more than 35% of the day, that's considered severe mouth breathing. Did you know that? I would think it'd be like 75%, but it's just 35% of the time is considered severe mouth breathing. And that nasal disuse causes all kinds of issues. So you don't get as much nitric oxide, you have less oxygen uptake. It doesn't warm and filter and humidify the air, and lead to enlarged tonsils and adenoids, can lead to more inflammation. And importantly, it decreases your quality of sleep. Just mouth breathing alone decreases your quality of sleep. Add on top of that snoring. Sleep disorder breathing is a spectrum up to obstructive sleep apnea. That's like the far end, like your house is on fire. But we want to stop it when there's just smoke in the kitchen, right? With the mouth breathing. Teeth grinding is often not just psychological stress, it's physiologic stress. They seem like they can't get enough air, and so their jaw is jutting forward to try to get more air. They're tossing and turning, restless sleeping. They wake up all the time, a super light sleeper. I just got an email about a 14-year-old that's still bedwetting. I mean, it happens all the time. And we often treat these patients and the bedwetting stops like the next night, right? Because we fixed the airway issue. And often it's a multidisciplinary problem. So they might need expansion, might need their tonsils and adenoids out as well, right? But tongue tie is often completely left off the differential diagnosis for bedwetting, these other sleep issues, right? Everyone knows taking out tonsils can help. And often expansion, people know about that, but they don't even think about tongue tie or myofunctional therapy can help. So anyway, hyperactivity, inattention, again, give them Ritalin. It's a medical problem, but there could be an underlying cause, right? It could be from poor sleep quality. Aggressive behavior, again, like give them a tranquilizer, but like it could be from poor sleep quality, airway issues. And at the end of the day, it leads to chronic systemic inflammation that leads to an increased risk of all kinds of death, like cancer and heart disease and diabetes, metabolic syndrome, neurodegenerative disorders. So the 4 leading causes of death in adults is caused by inflammation. Well, if you have sleep apnea, that's going to make your inflammation worse, right? All right. Here's our child form. Notice it's a history of issues as a baby right here. So nursing or bottle feeding issues. So speech, solid feeding, sleeping issues, and then like kind of other. Down here, this is lip tie issues. So someone comes in, they only have a few check marks there, probably not a tongue tie, maybe even a couple here, maybe not a tongue tie, just a lip tie, right? But if they come in and all these things, right, these are more tongue tie issues, okay? So if they check off like constipation, small appetite, and their speech delayed, and they had a history of issues as a baby, this person probably has a tongue tie and a lip tie based on the symptoms. It's like a functional approach to it. So we're looking not at just the anatomy of it, you got to look at the symptom, what it's causing. Because they're never going to come see us, or almost never, for just like, oh, if there's no perceived problem, right? I'm not going to go to the endodontist to get a root canal unless I'm pretty sure I need a root canal. I would never just show up, hey, can I have a root canal today? Which tooth? Like, I don't know, just pick one. You would never do that. No one ever wants us to laser their baby, right? Or their child. There's a reason why they're coming to see us. They want them to talk better or eat better. It affects adults too. So it does not just magically get better as you get older. Often adults have neck tension, TMJ issues, headaches, stress or anxiety, sleep apnea, speech issues. They get tired with singing. We've done a lot of opera singers, all kinds of stuff, right? And they've had jaw surgery like I had. They've had teeth extracted. They've had sinus surgery like I had, poor quality sleep, all the stuff. So how do you examine? How do you check for a tongue tie? You want to come from behind? That's the best way. Then you can see, mom can see. We're using gloves. We have a special board we use. This is a pediatric dentist from Germany. We're looking at her child. Now he's like probably 3 years old, but I can't get in there very easily. I don't want to get bit, so I use a mouth prop or a tooth chair, we call it. Pediatric dentistry have lots of names like that. But look at his tongue. It's almost to the tip. Did you see that? She didn't even know her child had a restricted tongue, and it's almost to the tip. So here's our assessment sheet. Won't have time to go over that, but we do have an assessment. We don't do like a HATLIF form or other BTAT. We use this form. And here's how to examine a baby for lip and tongue tie. Ready? The lips up. See how tight it is? The cheeks. Not obvious. All right, so that was the baby. Here's how we treated it, I believe. Oh, this is another exam video, and then I'll show you the treatment. So here's another one. I turned the sound off. You're welcome. But we're gonna lift up the lip first. We're gonna check the cheeks. That's probably class 2. We'll talk about that as well, but it's like in the middle. It's in the gingiva. Class 3 would be all the way down to the alveolar ridge. Class 1 on the buccal tie would be up in the mucosa. That's a class 4 tongue tie, or you could say type 1, Carrillo's type 1 or Cotwell class 4. Since they're the reverse of each other, I just like saying a percentage. So it's 100% to the tip, right? Often I'll just tell the parents it's 100%, 60%, 10%. Everyone can understand that, no matter which discipline you come from. So here's the treatment on that exact baby. So this is with the light scalpel CO2 laser. It just hovers above. What it's doing is it's just vaporizing the water molecules in the tissue. So it heats them to 100 degrees Celsius, the boiling point of water, and it turns to steam, takes the tissue with it, cauterizes the smaller vessels, capillaries, that kind of stuff. So there's typically minimal to no bleeding. So essentially what you're doing is an in vivo dissection of the tissue. It just disappears. Right, here's the tongue. Now, if I were to cut this with scissors, it would start bleeding right away, but instead with the laser, it just disappears. It's not a lightsaber. It's very, very safe. It's using a minimal wattage, like 1 watt, like very, very small. It's a 0.25 millimeter spot size, cuts like the width of a human hair at a time. So it's not cutting, it's not like you're just gonna slice someone's tongue off, right? We had one grandpa last week who's worried I was gonna slice his grandson's tongue off. That's not how it works, I promise. Anyway, we can be really precise with it and kind of pick off a little bit off the ridge there. If you see a little spot that's tight, we can just dab it and it's just like drawing with a pencil, right? Here's a 4-day-old. Mom is sleep deprived, emotional, really bad pain, lip curls under, clicking or smacking noise is real gassy, coughing, it's like aspirating possibly, hiccups a lot, and in utero hiccups. That's probably one of the earliest signs of a tongue tie, right? And this one's not obvious, right? It's not to the tip. This one might be halfway. And some people might call that like an Eiffel Tower presentation. This is the base. There's the spire right there. And so the lip is pretty tight, but it's thin, right? So it doesn't matter how like thick or thin it is. It matters if it's tight or not, if it's restricting. And so the thing is, the seal issues over here, the tongue issues plus the pain over here, right? On the form, that's kind of what they correlate to. And afterward, less gumming or chewing the nipple, passy stays in easier, sleeping longer. It was a 7, now it's a 1. Mom feels more confident, better emotional state, worth the drive 1,000 times. They had to drive far away. Now, more spitting up, that's okay though. Often we see that with improved breast drainage, so they're getting more milk out, better milk supply, less nipple shield, doesn't prefer one side over the other, right? All these things. Here's that treatment on that exact baby. So again, here's how we did it. So lots and lots of tension, pulling up tight. The baby's not asleep, just some topical numbing jelly, just like 2% lidocaine is what we use now, viscous lidocaine, and it just disappears, right? One mom said it just like erases it. Said, yes, it just erases it, right? We have laser safety glasses for the baby, for everyone in the room, assistants holding the head, baby is swaddled. We have the parents wait in the consult room. We'll borrow the baby. It's about 4 minutes and then come right back. And so lots and lots of tension under there, right in the middle, just a horizontal pass, and that diamond shape opens up. There it is. You can see it typically minimal to no bleeding. Occasionally, you'll get a little bit of bleeding. All right. Another important thing to remember is it's a spectrum of lip restriction. So this is the worst we've ever seen. This one's minimal. There's nothing there. So this one you wouldn't treat. Even this one we might not treat. It depends what the symptoms are, right? Depends what the symptoms are, but it's not blanching. This one's not right here. It doesn't look too bad. So that one might be fine. I don't know. It just depends. But some that look okay and they have a million symptoms, well, then we want to treat that one. So it depends on the symptoms. This one's blanching here. This one's notching the bone. This one's corded. This one does not flip up to the nostrils. There's a little dimple or a divot on the outside of the upper lip you can often see. Again, notching the bone here. So those are kind of features to look for, but they can be thin or thick. But this one's like the super tightest, shortest one I've ever seen. This one's really thick and to the tip. Sometimes they're translucent, really thin, close to the tip. These two, you guys know what happened here? Those ones were clipped previously. So those ones were cut by an ENT or at the hospital maybe, and they didn't get them back for follow-up, or else they would have seen that the symptoms didn't improve and that it stuck back together. So either it grew back together, it reattached because they didn't do stretches, or it was not released fully or a combination of the two. But without a pre-op and a post-op photo, I can't tell the difference between if it's a reattachment or it just was not, it's an incomplete release. So these ones, again, not obvious tongue ties. All of these, even this last one, were all causing symptoms for that individual baby. And then after treatment, they got better, or mom, baby and mom. It's a nursing breastfeeding dyad, right? Just to show you its varying degrees of elevation. So if you just peek in there with a tongue depressor, you're not going to see it. If you lift up, you'll see the fascia, the connective tissue start to bunch up. With 2 fingers, you can really get a good look. You'll see the fascia bunch up, and there it is, right? There's that frenum. Same thing in a child. This one's on a hygiene check. Saw this kid, we were just checking him for cavities, but I noticed it looked a little bit suspicious under there. So I pulled back, got this pretty tight, pulled back again, and hey, it's pretty restricted. What clued me off in the first place, though, do you guys see it? Right there. ONP, the bottom incisors are turning inward. Why are they turning inward? He's got plenty of room. They're turning inward because something's pulling them. What's pulling them? The frenum, the restricted frenum, right? And so what I do on a hygiene check, I'll say, hey, mom, does Johnny have any issues with speech or eating or sleeping? And they'll say, no, he's good, he's fine. Sometimes if they're like, I think he's fine, I say, well, speech would be like speech delay. Was he slow to start talking? Does he have any issues with R's or L's or S sounds or TH sounds? Is he a slow eater or a picky eater? Yeah, he does do that. Okay, does he grind his teeth at night? Come to think of it, he does grind his teeth. Does he toss and turn? Oh, yeah, you can't sleep with him. But in the beginning, when you asked him any sleep issues, they didn't know what that meant. This meant, does he go to bed on time? But that's not what it means. Or does he wake up in the middle of the night? It's the quality of sleep, not if he gets 10 hours, right? So varying amounts of tension. This is the same patient, just different amounts of tension. It looks like 4 different ways, right? And then there's the release afterwards. Same patient, just different amounts of tension. So again, symptoms and function are more important than the appearance. This one had perfect speech. This one on the right here was nonverbal. Now he also had autism, but often with autism or Down syndrome, cleft palate, premature babies, whatever, if there's a comorbidity, another issue, often everything is blamed on the autism. Everything is blamed on the Down syndrome, but you could have a tongue tie and autism, a tongue tie and Down syndrome, a tongue tie and a cleft palate, right? And so it happens pretty frequently. And so we take kids, that have autism, we release it, and everything doesn't get better, but maybe their speech is a little bit clearer and they can a little bit less picky and they're sleeping better and they can pay attention better. So the parents are happy, right? So that's something to look out for, is if they have any other issues, they could have a tongue tie as well. So here's cavities, so severe early childhood caries. This one's got like a dog leg. Sorry, this one's got a large diastema or the gap. This one has the dog leg here. This one's blanching. It's hard to brush up there. When they smile, you can't see their teeth at all. So those are all reasons to treat it in the toddler. But really what we need is a screening tool, because we don't want to over-treat. We also don't want to under-treat either. We want to get right in the middle. So it needs to be quick and easy, combine the symptoms, the function, the parent desires, and it needs to be useful. What's the point? So we don't care about this right now, the lingual palatal suction, that's for another day. But what we're looking at is the tongue range of motion ratio. So you should be able to lift like above 80%. If you open wide right now and lift your tongue up, you should be able to lift and get your tongue to the spot behind your top 2 teeth without closing your mouth, right? If you can get like 50 to 80% of the way, that's a grade 2. Now, grade 3, that's less than 50%. That's below average. That's very concerning. If you're less than 25%, significantly below average, very, very concerning, right? So that's what we're going to check on our hygiene patients. So if you're a dentist, tomorrow you can check your hygiene patients. If you're a physician, therapist, you can check your clients or check your patients tomorrow on like a well visit. But just have them lift the tongue up. That's the best test. Sticking the tongue out is the worst test. Someone told me just yesterday, he can stick it past the wet, dry line of the lips. That's like from 1970s. This is the update. This is the new information. Lifting the tongue is what's important for speech, eating, sleeping, breastfeeding, breathing, all the things. It's the mid-tongue elevation. It's not just lifting the front of the tongue, it's getting the middle of the tongue up. And so that's what lingual palatal suction measures, but we don't have time for that right now. One thing to keep in mind, though, is when you're lifting the tongue up, some people lift the floor of the mouth with it. So what you can do is you can take a gloved finger, hold down behind the incisors, and then that'll give you the true mobility for the tongue range of motion ratio. Here's an example, a real life example from our patients. This is a 39-year-old opera singer. She's had obstructive sleep apnea since 2017. She uses CPAP at night, mouth open, snoring, gasps for air, TMJ issues, neck or shoulder tension, reflux, constipation, stress or anxiety as long as she can remember. She was bottle fed as a baby. She has trouble singing. So if you look in here, she just lifts her tongue up. Looks like she's a grade 2, right? She can lift it pretty well, maybe 70%. But when you hold down, she's actually like a grade 3, maybe even a grade 4. She can't hardly lift up at all. But afterward, holding down, now she goes up way higher, right? And then for adults, for teenagers, if they're cooperative kids, we'll often suture them, get primary intention closure. You still have to do stretches with sutures. You can just wait like 3 days to start stretches. And the sutures fall out between days 3 and 7. So afterward, what happened? Less neck and shoulder tension right away. This is within a week. Less TMJ issues. She's happy about that. Less moving at night. Less need for sleep appliance. Less grinding your teeth. Easier with sounds. Singing is easier. So she was very happy. Less jaw tension. Posture is better. She's sitting up straighter because she can breathe better. Crazy stuff. So I myself went over and here's my pictures. That's why I put it in here. So this is before. This is before. This is afterward. Goes up much higher now. You can see it lifts up much higher now. This is in suction hold, lifts up much higher. Healed really nicely. This is about 2 months ago. I went to see Dr. Zaghi at the Breathe Institute, and we celebrated afterward. We went to Universal Studios to celebrate a good tongue tie release with his son, Maxim. And we asked this nice lady to take our picture, and she took the picture. She said, "Cute family." Thought that was funny. We were in Southern California and Los Angeles, but it was a lot of fun, and he's a good friend. So if you have any questions about adults, teenagers, definitely take the Breathe course. It works really well, or go visit the Breathe Institute. So anyway, so step 2. So all that was step 1. So the tongue range of motion ratio, how high can you lift up, right? Step 2, the tongue restriction questionnaire. So we released this in 2021. It's basically the greatest hits of our form I showed you earlier. Instead of 50 items, it's like 15 items. So if they have a few check marks on here, it's significantly impacting quality of life. They can't lift up very high. They probably need a referral to a tongue tie center, right? To our tongue tie center. And so what that's saying is not like they have a tongue tie. It's saying they need to get like a full evaluation. It's just a screening form. Just like the PSQ, the Pediatric Sleep Questionnaire, screening for obstructive sleep apnea. If they score high on that, above 7.5, then they need to go get screened, get sleep study or something like that, right? Now, if you want to download the TRQ or any of these other forms I'm showing you, please go to our website, tonguetieal.com/professionals. Scan that QR code. You can download all of the research articles I'm showing you, as well as all of our forms we use. They're Word documents. You can edit them, use them yourself, right? So that's the TRQ. Then someone said, like, make it like even easier. So here, okay, here's even easier, right? If it's to the tip and they have lots of symptoms, that's a slam dunk. If it's to the tip and there's a few symptoms, that's also low-hanging fruit. We have a peach tree in our yard. There's several hundred peaches. I'm not going to tell you where I live because you'll come take all my peaches. But there's several hundred peaches out there. They're like the size of grapes right now, but in like a couple months, they're going to be like huge, juicy, just like that. So low-hanging fruit, right? If it's obvious, it's to the tip tongue tie, there's a few symptoms, still worth treating. Here's the one that gets a lot of people though. When it's minimal appearance, but they have lots of symptoms. So if they come in, they have like every symptom, you look in there and it's just a little bit there, please, it's worth treating those also. Now, if I had to take that child, put them to sleep at Children's Hospital, they're gonna get 4 bills from Children's. I have to be more sure, okay, we're going to get some really good results, right? We have to get even better results to offset the risk and the added expense to the parents. But if it's in the office, we can do it the same day, just a little bit of numbing jelly. The stretches are the worst part, and then the cost is way down because we're not paying an anesthesiologist, a facility fee, a CRNA. So the cost is way down. We can get mediocre or even medium amount of improvement, and the parents are still thrilled, right? And so the only time you're really waiting is if it's minimal appearance and there's few symptoms, then just wait on it. It might be something else, right? It could be allergies. It could be they need an expander. I don't know. So briefly, you guys have probably seen this before, but there's something called evidence-based medicine, evidence-based dentistry. This is from Oxford, but basically a randomized control trial, or RCT, would be like level 1 evidence, or systematic review would be like level 1 evidence. A cohort study is level 2 evidence, right? So it's still good. It's not quite as good as randomizing it. Case control studies, be level 3, a case series. So I'll show you like later on in this presentation, I'll show you like 3 or 4 patients in a row. That's a case series, right? That's level 4 evidence. Expert opinion is level 5. So if I just say like tongue tie causes, improves constipation, that's an opinion, right? Do I have anything to back that up? Well, here's a case series. Here's 5 patients that improved in their constipation afterward. I can probably show you 100, but here's 5, right? But then I take a cohort study. That means before we even treat them and say you're in the study, that's a prospective cohort study. I'll show you that we did it already. That's level 2 evidence. So that trumps your level 5 opinions. You say tongue tie doesn't impact speech or tongue tie doesn't affect speech delay. Well, I have a level 2 evidence showing that it does. So that trumps the opinion that tongue ties do not affect speech. And just in case anyone is wondering, the New York Times is below expert opinion, right? The New York Times is below expert opinion, in case you're wondering where they fit on that level of evidence, okay? So here's our level 2 study, prospective cohort study. So before we even treated them, we said, you're in the study. Whether it gets better or not, we're going to report it. End up with 37 children, significantly better speech, eating, and sleeping at 1 week and 1 month. So it was improved and it stayed improved. These are often like preschoolers, but again, age 1 to 12. And first study to show improvements in speech delay, picky eating, slow eating. Like before this, there was 1 study on solid feeding. I guess 2. 1 from 2018 that we did, and then Brooks 2019. So there's 2 studies, very, very small, showing improvements in solid feeding. And ours was the first in 2018. But this is the first to really show it well, that like it affects solid feeding, choking, snoring, restless sleeping, published in Clinical Pediatrics, the Pediatrician Journal in 2020. Right, here's another one briefly, Dr. Gahari's study. I put this one in here. This is really key because it's a randomized control trial. So that's level 1 evidence, right? And people say, well, people say it helps with nipple pain, which is subjective. Maybe it just like tricked the moms. They're just thinking it's better because there is something called a procedure bias. If you do a procedure on someone, it could be a placebo effect maybe, right? But that's not what he did here. He has a computerized bottle nipple that gives you like a data readout. So you have like numbers you can graph, you can do statistics on. Now we can do a study with that. So he released only posterior tongue tie. So people say, oh, anterior tongue tie, that affects it. But posterior tongue tie, there's no such thing. It doesn't exist, right? He did it with the CO2 laser, the light scalpel, saw statistically and clinically significant improvements in 11 objective. So it means not just the mom's perception. This is objective feeding metrics. They could move their tongue faster. It was more rhythmic, more coordinated, more adaptable, right? But also breastfeeding improved, but mom's confidence improved, but not in the control group that was untreated. Reflux improved, but not in the control group. Nipple pain improved significantly in the surgical group, but not in the control group. It's a good study. I highly recommend looking it up. Another study here, this is looking backwards, right? So basically the AAPD guidelines, the pediatric dentistry guidelines say, don't treat a lip tie before the permanent canines are in. It could cause scar tissue. Well, there's no evidence for that. It's been passed down for at least 50, 70 years. And they said, if you have evidence to the contrary, show us that. So I did. I said, you know what? I'm going to go back to all our patients, went through every patient that had a lip tie treated and they had teeth. And then we could get them back for a follow-up visit or a hygiene visit or something. 192 total patients. We got 109 to follow up, which is pretty good. And then had post-op images taken, right? So here's like the images we take, and we can measure that with a perio probe and see how wide it is. And guess what? The width decreased in 94.5% of the patients. So now I can't say that it caused that because I don't have a randomized control trial. But what I can say is that there's not scar tissue preventing closure, right? Half were done with CO2, half were with the diode. It didn't matter. They all closed up. There was no difference. 13 had permanent teeth. 96 had primary teeth because that was the main thing. This is published in International Orthodontics, right? That's the European Orthodontic Society's journal. It's a high impact journal. Here's a picture. Before, this is afterward. That's the diode. See, it looks kind of more charred, but look, it healed beautifully. And then the gap closed up. So this is probably like 6 months, a year later. This is probably another year after that. It keeps closing up because teeth drift mesially. That's why the dentists have to do spacers to prevent space loss for molars. The teeth want to move toward the midline. This is released with CO2 laser. This one's also with CO2 laser. Here's before, here's immediately afterward, like seconds after, and it closed up a year later, right? No braces needed. Here's the study. It is the most downloaded article for the past couple years in this journal, right? Because it's a big deal that people, we're dispelling this like long-standing dogma, right? And here's more pictures in case you don't believe me, but it closed up. It's so much easier. I mean, who's going to brush their teeth easier, right? If you run into this, that hurts. It doesn't feel good. You're pulling up on it, it hurts. All right, this is so much easier to keep clean, more cosmetic. The teeth are together. No need for braces. Here's an older child. He's probably 11 maybe. So his canines are almost in already. We released it. His teeth closed up beautifully. He doesn't even need braces. Saved him $6,000, right? It's a nice service. Here's a 7-year follow-up in case you're like, well, that wasn't the baby teeth, but what if the permanent teeth come in? Okay, I've got you covered. 2016, right? This is just 6 months later. They closed up. This is last year, almost on Valentine's Day. Same patient, boom, permanent teeth came in, looks great. Same exact patient. And it's not just tongue tie. Often I'm speaking on this. That's my friend Dr. Zaghi. He's already kind of red pilled you like Morpheus, but it's not just tongue tie. So this lecture is 1 hour. It's on tongue tie. There's also tongue tone, so myofunctional exercises, the resting posture, the tongue, the lip, the cheeks, and then tongue space. So if you don't have enough room for the tongue, like a 6-foot tiger in a 3-foot cage, right? Inadequate tongue space can also impact similar stuff to tongue tie because it pushes the tongue further back in the throat. They can't sleep as well. They can't breathe as well. So you need some expansion or uprighting, skeletal expansion if you need to. Briefly, because we're kind of on the research section of this 1 hour talk. This is a new article just came out in October. So the Buccal Freenham, we released Buccal ties. We've been doing it for many, many years, but there's like zero, like not even one study. And so that's dangerous. If you're doing a surgical procedure, you don't have a study to prove it or to back it up, then that leaves you, if the dental board or medical board, ethics board, you could be in trouble. And so we did the largest survey I know of tongue tie issues. It was 466 healthcare professionals from over 12 different countries. 87% indicated they assess for buccal ties or buccal restrictions. Typically, it's a finger sweep. They'll look, their visual inspection, check and see if it's blanching or turning white, and then a functional assessment, so what symptoms are there. 94% of providers said they need objective, so like what they can see and feel, and subjective findings, what the patient reports, needed for the diagnosis. So you don't just treat just based on symptoms. You're not treating just based on the feel. You combine it together, just like tongue tie. So probably 5 to 10% of infants might be affected by cheek ties. Most of the providers release buccal ties simultaneously, so at the same time as the tongue, if it's needed, because you don't want to put the baby through 2 procedures. Occasionally, we'll do lip and tongue, and then if the mom's on the fence about it, we'll just wait, and then we'll do the cheek ties later. In those cases, we've done cheek ties later because mom did not want to do it at the same time for whatever reason. Almost always, the parents say, "Oh my gosh, this is way better. Like I didn't realize." So we know that the cheek ties can independently impact, right, or buccal ties can independently affect infant feeding. Other stuff is we don't have as much data for that, but 3/4 recommended stretches is necessary for optimal healing. So you do have to stretch cheek ties, just like if you got your ear pierced and your nose pierced and your lip pierced, like you got to wear the lip ring or the nose ring and the earring, or else it'll close up, right? Wherever you don't do the stretches that you've released, it's going to close back up. So what other symptoms can it cause? This is all in the article, so I won't go over it. But infants, it's mainly seal issues during feeding. They can't flange the lips out right. They'll leak milk out. Children, maybe food pocketing, straw drinking, lip rounding, trouble brushing the teeth. You'll run into it. Adults, same thing, teeth brushing, gingival recession, denture retention issues. So if you're a general dentist, like why are my denture patients, why can't they keep their maxillary, their top denture in? Could be a cheek tie. I don't know. Fascial tension. One lady, we released her cheek tie. I kid you not, her tinnitus, the ringing in her ear that she'd had for over a decade, disappeared. So there's all this like weird stuff that we don't know. That's anecdote. That's one patient, but I don't know. There's like weird stuff that we don't know of. So there was no classification system for cheek ties. So we designated one here. Basically, class 1's in the mucosa. Class 2 is in the gingiva, in the middle. Class 3 is at the alveolar ridge, right? Came up with a cute acrostic. Everyone loves a good acrostic. So is it blanching the tissue? Is it uncomfortable to palpate? Is there a clinical impact? Like what symptoms are there? Are they compensating? Then where does it attach? So it's not just the attachment site, right? It's all these other things. Is there limited range of motion? They can't move their cheeks well. All right, when you treat it, you laser it, it disappears, minimal to no bleeding. There are some little like arterioles up there, so you do have to be careful. Just don't go too deep. You can get some bleeding. But anyway, that's what it looks like healing. Heals nicely. We give an appendix of how to treat it. Okay, now the New York Times article. I won't belabor the point. Right before Christmas, as a nice Christmas gift to us, they decided to release this article inside the booming business of cutting babies' tongues. And then the Daily Mail and others pick it up and they say, US doctors are wrongly slicing off bits. This is not made, this is real. Slicing off bits of babies' tongues to make breastfeeding easier, leaving them with lifelong deformities, investigation finds. They don't do their own investigation. This is just what the New York Times said, right? But they're selling advertisements. Pay us. So this is what's called clickbait, right? They want you to click this. They have a sensational headline because they know that if it's enraging, it's engaging. You'll click it and share it and comment. There's thousands of comments of angry moms that are like, we had this done and it helped. People are like, oh yeah, it doesn't help at all. And so all that to say, oh, in other news, here's the best baby formula. Katie Thomas, they reached out to me right, from the New York Times. She's the author of the piece. They reached out to me to try to get me to interview for it. I decided not to do it. And, but I know Dr. Zoggy did, Dr. Kotler did, gave them hours of their time, went over all the research. Scott Siegel, who is also a light scalpel provider, an MD, so he's a physician and a dentist. He's an oral surgeon in New York City. He's been doing this for 20 years. They followed his patients. They all got better. Did they report that in the article? No, they did not report that in the article. So I decided to write the real story of the booming business of tongue tie. Here's my response to it. And now, oh, so here's a patient said, thank you so much for writing this response. This article made us second guess ourselves while we're doing the stretches. It was affecting patients. They're like, what have I done? He like tricked us, right? Look at this. If you type this in, I typed this in today. I kid you not, booming business of tongue tie. It popped up #1 above the New York Times. Boom. I just thought that was funny, right? That's like epic. So anyway, and I heard saw on a Zoom earlier with someone. This is my second Zoom today, and they said in Ohio is the same thing. So anyway, your results may vary because Google's individualized, but I thought that was pretty cool. All right, so technique sensitive. So what's interesting is treating tongue ties, and this is partly where like people are like, well, tongue tie treatment doesn't work. We've seen that kids with tongue ties and they're fine, you know. So here's if I'm going to do a filling, right, for your tooth, it's pretty complicated. You have to prep it, remove all the decay, rinse it, dry it, etch it, rinse, dry, not too much, bond, air dry, not too much, cure, fill, cure, polish. And of course, if it gets wet or anything like that, contaminated, it's not going to work. So the restoration will not work as well if it's done out of order or if you skip any steps, right? You don't do it properly, you dry it too much, too little, it's too wet, you don't cure for long enough, all these things, they won't work. Tongue tie, you have to do the history, the assessment, the diagnosis, the treatment, aftercare, and follow-up. It will not work as well if it's done out of order or if you skip steps, right? So it's really silly to say that a filling doesn't work if you do the filling wrong. Likewise, it's silly to say treating tongue ties don't work if you do it incorrectly or incompletely. Okay, it is technique sensitive. You do have to do it the right way. So how do you do it the right way? Again, this one lecture is not enough to just start doing it, but 5 keys for a proper release. This is straight out of Tongue Tied Academy. We go in depth in this for many hours. But anesthesia, you want them numb, precision, tension, look and feel for fascia, size, and shape. Anyone can do this, right? You can do this. It's easier than a filling. If you're a dentist, you can do this, right? Physician, nurse practitioners, midwives, right? A lot of those people can do this procedure. So ensure the patient's comfortable to achieve a full release, cause the least amount of pain, of course. So you can do it with scissors, cautery, diode, CO2 laser. You want controlled, efficient cutting. About 10 seconds or less is typically the sweet spot. That's about as long as you're going to get on a toddler, right? On a 2-year-old, that's all you're going to get. You don't, if it's taking a minute per area, like with the diode laser, or 2 minutes per area, that's way too long. Okay. We'll inject lidocaine if they're older. If they're over age 4, we'll inject some lidocaine with epinephrine. If they're under 12 months, we'll do a dab of 2% viscous lidocaine. We're from the South. I don't know, a dab, not very much, just a little bit. Compounded topical. We use like strong lidocaine, prilocaine, tetracaine, over 12 months old. And it really numbs it so well. They don't feel an injection typically. Works well for dental ops too, if you're doing dental treatment. So not too high, not too low. This one, they cut into the body of the tongue. This one, I don't even know where they cut. This kid has braces. They totally missed it. There's a little cut there. There's a little cut there. But it was insufficient. It didn't work right. Right? This one, they cut into the salivary ducts. Right here. I guess I have a funny story. Not this one on the next slide. But do not cut near the ridge, please. So this person was cut, and I guess it was a well-meaning pediatrician that did this. We love our pediatricians. But this one, they cut here just a little bit, and they got a little bit, and that was fine. But then they decided to do this large gash down here. This is 3 weeks later. The baby still has this large ulcer that's bleeding. That's messy. That's not good. Like, I don't want you to get a lawsuit or something. Please don't do that. So, and I saw a couple of them come in like that. So, thankfully the OB talked to him for me. But this one is very restricted. See, these ones, if the provider that did these saw them back for follow-up, realized the symptoms didn't get better, looked underneath, they'd see it reattached, or they didn't get it all. The tongue should flip all the way back. Tongue should flip all the way back. You shouldn't see any of the dorsal, the top of the tongue. Right here, you see all these top of the tongue. You shouldn't see any of that. You should only see the ventral or undersurface of the tongue. This one was clipped as a baby. He's 36. Now it goes all the way up afterward. Right? Look at this one. They cut in the salivary ducts. They cut right there. So I had to go up here and then come down. What's funny is this little baby, she's now 6 or 7 years old. Her sister came in. They just had another baby, came in yesterday. And I said, oh, hey, good to see y'all. We've been here before. Ours was the one that had the salivary glands. I said, yes, I know exactly who you're talking about. I still use her picture when I lecture 6 years later. All right, here's a 2-week-old, lots of issues, 7 out of 10 pains. You think, well, maybe it's less obvious because often those are bad pain, but not always. It could be to the tip. Let's take a look to the tip. Both parents are physicians. Dad's a cardiologist. You know, baby's having all this trouble nursing. We release it, doing better, less pain, more spitting up though, but we're getting more milk out. Passy stays in better, deeper latch, less falling asleep. Here's the procedure on that exact baby, okay? Just want to lift up real tight. It just disappears just a little bit at a time. They're not asleep. It just takes maybe 10, 15 seconds for the lip, maybe 10 seconds for the tongue. That's about all it takes. It's that quick. All right, super tight. We're not just going to get it halfway and stop like those other ones we saw. We're going to get the whole thing. So don't stop there. Keep going. There's all that fascia back there. I'm going to get a little bit above and below. I can get that little piece off the gum pad right there. Just pick it out. It's so precise. It's just like a pen. Now you just kind of draw on it, and there it is. It just erases it. Here's one, the very next patient after that one. This is on a live course day, so I got some nice videos, but this is so sad to me. Are you presently breastfeeding? No. How long since you stopped? 1.5 months. So they tried for a couple weeks. They couldn't breastfeed. But look, they switched to a bottle. It's not any easier. It's difficult to bottle feed him. All these things, popping off and on, gagging, gumming, short sleeping, moves a lot in his sleep. The airway issues start now. Noisy breathing, snoring, short sleeping, right? Clicking or smacking noise, colic, that's awful. They are really on the struggle bus. Most patients that come to see us, it looks just like this. It takes an hour to feed them, like really, really struggling, right? They do not want to put their baby through this. 2 months old, no one could figure out what the problem is. Can you see the problem? It's to the tip, and it's really, really thick. It's like a heart, right? It's a heart shape. The lip is also pretty tight, and they had the lip issues, so we treated the lip as well. Minimal bleeding, a little bit though. When it's to the tip and thick like that, you'll often have a vessel running right in the middle, so you might get a little bit of bleeding, okay? Here's this one, less falling asleep, sliding off and on nipple less gassy. These patients were back to back, right after each one after another. Sleeping longer, less snoring, less moving in sleep. Nose is less congested, probably from less spit up, less frustrated. Sometimes they'll babble more even. He gained almost 1 pound in a week, so gained really well. Normal weight gains like 1 ounce a day. So here's the lip, lots of tension. Pull up real tight. Slow hand speed, the slower you move the laser, the faster it will cut. You get all the way up in the vestibule. We don't want to take too high. We're not going to go up like into the nose or anything, but just there we go and stop. Okay. That's all we need. Onto the tongue. Again, lots of tension. We'll have an assistant stabilize the chin. We have suction there, suctioning up the laser plume. And there we go. Disappears. Don't stop there. That's not it. Right? You want to get the whole tongue release so it elevates fully. We're going to get the most elevation possible because we know that we don't know at what point is too tight for that individual baby for later on, for speech and eating, sleeping, or currently for feeding reasons, right? And there it is. So where do you start? So watch carefully. Start right here, go in little circles until it starts to give way, and then you do inverted U pattern like this. all the way up, all the way up, all the way up. Try not to go over the same area, and then you're done. Sometimes you get a little tag of tissue, you can hit that right there. And that's you end up with like a teardrop shape. For the tongue, you start right in the middle and just go side to side. That's all you do, side to side like that. And then it opens up the diamond shape, right? Not up here like we saw, not down here, definitely not down there at that big gash. Skinny diamond is what you want, triangle or teardrop shape right there. Now you're not trying to make a diamond. Just when you have a triangular prism, you make a horizontal cut, you get a diamond naturally, right? Here's our consult room. It used to be my office for the nursing room, and then I got my office back. That's good. And now we have 5 consult rooms / nursing rooms. So the mom, they come in there, we do the exam in there. We'll borrow the baby for a few minutes, bring them right back. They can nurse right away. Have a nursing pillow, a scale. We can do a weighted feed, all that kind of stuff. If you want the scale, that's the scale we use. And it's all in the if you download the forms, it's all in there. The materials we use, all this stuff, like where we get everything, is all in the forms as well. But we use a swaddle, a special lap board, a little anesthesia donut, keep their airway well. Crying baby is a healthy baby. Notice this is the diode. This is the BioLace iLace pen. It's about $3,000, but the tips are like $15. So it's like a printer, right? You buy the $60 printer and then the toner cartridge is $100. That's where they get you. So over time, this will actually end up costing more than a CO2 laser, which has a higher initial cost, but minimal to no ongoing cost with the CO2 laser, right? And here's I was injecting, even on babies, I feel bad. I would put some lidocaine and inject it into the frenum because I knew it was taking a minute per area. So here's our CO2 setup. This is pretty cool. This holds the suction. You can get on Amazon. It's called a plamp, but there's no injection. We have a tooth chair. Here's the tip, a suction tip, laser safety glasses, all that stuff. So basically, there's 3 things we're looking for in a good tool: good hemostasis, efficient cutting, minimal thermal damage. Scissors are very efficient. Takes 1 second. It cuts faster than the CO2 laser. Scalpel also faster, but they're always sharp. So if the baby moves at all or the toddler moves, boom, you're going to slice something, right? Erbium laser is also pretty quick, but they don't have good hemostasis. They're going to keep bleeding for 5, 10 minutes, 15 minutes afterward. And on a 2-year-old that's running around getting blood all over the walls in your office, you don't want that, okay? It's going to make a mess. You also want, again, good hemostasis. So a diode laser is excellent hemostasis, even better than CO2, right? It will stop the bleeding really well. Nd:YAG can too, but it's not an efficient cutter. It'll take much longer. There's only one, though, that has efficient cutting, good hemostasis, and minimal thermal damage. All right, so electrosurge, that also is an efficient cutter and hemostasis, but it can cause thermal damage that goes like a centimeter, like pretty deep into the tissue. So the CO2 laser is the only one that combines the 3 of those. That's why this wavelength in particular works better. So briefly, here's a diode. That's what it looks like right afterward. It does not wipe off. CO2 is much cleaner cut, but even the diode can heal nicely. So don't hear me bashing on diode. We used one for 18 months. When I switched to the CO2 laser, we had fewer post-op phone calls. Now, I still call and check on everyone and check on them at night, but like I don't have any phone calls after that. They're not calling me, right? With like saying my baby won't eat. Did you do Tylenol? Yes, we did Tylenol. They still won't eat. With diode, we had at least 1 or 2 of those a week where they would not eat as like a nursing strike, right? During the procedure, laser safety glasses, assistant, 1 or 2 assistants, cameras ready to go before we even start. Laser safety officer, eyewear, evacuation systems, you're suctioning up, laser news sign, doors closed. Here's a diode. Don't quite have time for this one. It's pretty slow. I won't show the whole thing, but this is just so you can see it. This is the diode laser. So what it does, it heats that glass tip to 700, 1,000 degrees Celsius, and it just gets white hot, and then it just burns the crap out of the tissue. You could also use a hot paper clip and a Bunsen burner. Would work very similar. But anyway, it's not using the laser as a laser, using it as a hot tip. And so the difference is, here's the same procedure. I think I have it after this. Oh yeah, if you want to see our new settings, this is 3 watts. This is for the lip, for an infant or for a child, or if it's like an adult, we'll start with these for the tongue, or if it's an uncooperative toddler. So 3 watts, 20 hertz. I used to do 29 hertz. I like the 20 hertz a little bit better. 80% duty cycle bumped up a little bit. So 2.4 average watts. And then if you want to take a picture, you can. And then for the tongue, for an infant or child tongue, we'll typically use this one. 2 watts, 20 hertz, 80% duty cycle. Oh yeah, non-super pulse for both of them. So what's the difference? So I'll do the lip first, and then I'll press the down button 1 time, and then that puts me at 2 watts, and then we're ready to go. So I'm not fooling around with a bunch of buttons during the procedure. just quick, get in, get out. These are starting settings. Sometimes I'll adjust it, but typically like 90% of the time is what I'm using. Here's the same procedure on an older kid. And here's with the CO2, the light scalpel. It's pretty quick. As you can see, it's not touching the tissue. Again, it's heating the water molecules with the photons from the laser. So it's actually using the laser as a laser, and it just disappears, right? In real time. What you see is what you get. Okay. And then we're almost done with this one. Like already, it's just started. Versus the diode, it goes on much longer than that, but trying to keep it the time here. I know you guys are getting tired. It's 8:30 here. So treating toddlers, positive attitude, patience, and confidence, just like training velociraptors, right? Sometimes it feels like this in the pediatric dental office, but I'll show you guys how to do it. Here's a 2-year-old, no general anesthesia. Mom is there, dad's there. Dad's going to hold his hands. Mom will hold the feet. Assistant holds the head. Do not let the parents hold the head. And then super quick, here's that patient. No shots, just some topical. We get through the whole thing basically before he even feels it. And then he decides to chomp down on my finger right there. That's why I leave this video in there to remind you, friendly service announcement, PSA, make sure that you always use a tooth chair or mouth prop. Here's an example. Here's another one. So there's a molt mouth prop. I got smarter, and now we can get all the fascia. I'm going to check it with my finger and feel it. Make sure it's smooth. See how thick it still is under there? That's still there. It's still holding the tongue down. So I'm going to release that a little bit more. There's a little bit more in the median lingual septum, and then there's a vessel that'll pop out on the side here in just a second. That's the deep lingual vein. Watch for it. See it right there? So if you hit that, it'll make a mess. Could be dangerous, but it'll make a mess if you hit it. So what to do if you hit it? Well, the best defense is a good offense. Stay midline. You don't see that till you go further wide. If you do see a little bit of bleeding, if I did hit it just a little bit, do not try to laser it more to get it to stop. It will not stop, right? The CO2 diode doesn't matter. It will not stop that big of a vessel, right? Direct, firm gauze pressure right on it, 10, 15 minutes if needed. The key is do not change the gauze out, right? Now, if they have a feeding strike, make sure the proper dose of Tylenol. We dose it 1/4 ml per pound for 6 to 11 pounds. So 6-pound baby gets 1.25, 7-pound baby gets 1.5, 8-pound baby 1.75, etc. Don't go too deep. If you cut muscle, it's going to hurt more. A diode is going to hurt more. If they're real tense and tight, they're going to like already in attack mode. They're not in chill mode. Ideally, they've seen body work first. So a chiropractor, PT, osteopath, CST, something to just help them just relax. So they're in, parasympathetic instead of sympathetic or fight or flight. So if they are in fight or flight and you release them, it's okay, but they're going to have a harder time nursing. So ideally, they do that before and after. Reattachment, this is the biggest risk is reattachment. Have the parents practice the stretches in the office before leaving. That's really helped. We follow up at 7 to 10 days. Most people do not push hard enough. They don't want to hurt their baby. I also don't want to hurt their baby. But I also know that long-term, it's going to hurt their baby more if their tongue is tied down or if they have to do the procedure over again and then 4 more weeks of stretches. So we'll do a deeper stretch. I'll show you that briefly. This is the deep lingual vein. Don't hit that. Sometimes there's extra muscle. If you see that, there's muscle under there, and you will have to take some muscle, right? But we're not trying to take muscle routinely in babies or kids. This one, there's nothing like to show you that there's anything particular on that one. Look at that, though. These large cavernous veins right under there. If you had scissors on that one and just went and cut that, it could be a mess. It could be dangerous, right? So you do have to be careful, certainly. Here's one. I had a tented appearance. I said, this will be a good one for a video because I know it has muscle under there. And right here, watch, as soon as we go through the mucosa, that's muscle. That's some extra muscle that shouldn't be there. So we're cutting through some muscle, and then we'll get back to some fascia right after that. So still muscle. The tongue, notice it does not lift up at all. So I'm having to still release, just staying midline, slow, making sure we get it all, checking it. Now you can see like an opalescent kind of hue. That's some more fascia. So, and then we'll get to the actual genioglossus muscle underneath. So see the fascia again, and then there's more genioglossus. But you can't see that with scissors. If I did that with scissors or even electrosurge, it would bleed so much you couldn't see it. Now they have to do good stretches to hold it back, right? So it doesn't stick back together. Sometimes there's a vessel right in the middle you got to watch out for. Bleeding, look at this one. A lot of bleeding. Nothing there to tell you it's going to bleed a lot, right? This one was really tricky. You had to go kind of like this because their salivary ducts had already gotten wrapped around the frenum kind of weird. Anyway, that one bled a lot. Just be careful. You can do it wrong with the lasers. This is with the diode. They use silver nitrate to stop the bleeding. That's why it looks all like nasty. It's a chemical burn, significant post-op pain, nursing strike, and of course, post it on Facebook for everyone to see. So please don't let this be you, right? Aftercare. It heals very rapidly by secondary intentions. That's the diamond shape, and it's going to close inward. You want the curtains to close. You don't want the window to shut, okay? Mom can nurse right away. It can look like infection or pus, but it's not. Often they'll drool more because it's sore. They don't want to swallow as much. Tylenol is great. They have Genexa, like organic version of Tylenol now. Motrin if they're over 6 months old. Again, it's all based per pound. Ideally nursing, but nursing is more effort. So bottles are fine. Shield is fine, a nursing shield. Syringe feeding, cup feeding, just get milk in the baby however you can. Often it's a couple days, 24, 48 hours, it's sore. Sometimes they'll have, 1, 2 better feeds the first day, 2 better feeds the next day, 3 better feeds the next day, 4 better feeds the next day, kind of like that. Takes some time. I call them, they have my cell phone number. This is what you want it to look like. You want it to heal really nicely and open like that. You don't want it sticking back together. These ones are sticking back together. See that horizontal line right there? But this one's like real thick in the middle. They were doing stretches with 2 fingers like this. We do stretches with 1 finger right in the middle. I'll show you that too. This one's like a pancake, right? So if you just push down here into and up like a J shape like that, you'll see it'll just stretch back out right away. Okay, I have a video on it to show you. We show the parents and then we have them put on gloves and practice too. Recommend 4 weeks, 3 times a day. We used to say 4 to 6 times a day for 3 weeks. So it's kind of swapped now. But what we found is the first week almost doesn't count because people aren't going to push hard enough sometimes. And so that first week, they're going to do it. It won't be quite enough. And so then they came back and we told them 4 more weeks or 3 more weeks. And they felt like, down because it was only 3 weeks to begin with. They thought they only had 2 left and now they got 3 more. So now we just say 4 weeks. Then after the deeper stretch, it's 3 weeks after that. And we get really good healing most of the time, right? Reattachment rate less than 1%, way less than 1%. And then 3 times per day. We used to say 4 to 6 times a day. We found 3 times per day, morning, noon, and night. That's the most you can reasonably expect someone to do a high quality stretch. Otherwise, we're going to do 6 mediocre stretches that aren't going to help. Keep it playful if you can. You can do some baby massage their face, massage their body, make some funny noises, right? Here's how we recommend to do it. Tongue-tie stretching for infants. Once you do these stretches 3 times a day for 4 weeks, we'll start with the upper lip, we'll lift up all the way, and flange it all the way out, and massage right on the site. That's really important. Get all the way up in the vestibule about 3 times. The tongue, hold the lower gum pad with your. That's so key. Hold the gum pad. Otherwise, they'll bite you. Pretty firm right on the diamond. Harder than you think. Your baby had cheek tie release. Go up on the cheek in the vestibule on both sides, just about 3 times. The same thing, just kind of separating the tissue out. Make sure it looks good. One more time. Here it is again. So lift the lip up all the way. It's real quick, not taking minutes and minutes. Just get in there and get out. Push right on it. Pretty firm pressure. The babies do not like it. If there's a better way, we would do that. Trust me. Hold the gum pad with your thumb, 1 index finger, and watch out. See that slipped back. So push really good. Don't let the tongue slip back. About 3 times right on there so you see the whole diamond open up. Now a deeper stretch. If you don't come back for a follow-up at 1 week, do this, or if symptoms come back at any point. So this is 3 weeks later. There's still a string there. It came back. It's going to push down right on the string, just like a normal stretch, but right in the middle. Notice it opened up some. Stroke it back a couple more times. Let's see, it'll open up some more. There will be a little bit of bleeding whenever you do this, and then it opened back up, but now restore the function of the tongue, and then symptoms should improve afterward. If you do have any questions, please contact us. So that video is on our YouTube channel. Like and subscribe. I'm just kidding. I'm not Mr. Beast. But anyway, yeah, you want to have your patients show them that video, show them, make your own video, but the deeper stretch is so key, right? For kids, stretching 2 times a day, so once in the morning, once at night, they're at school. That's about as good as you're going to get on like a 3-year-old, is once in the morning, once at night. Quality over quantity. Best results work with speech or myo. Typically, myo is like twice a day or as directed. Again, most of them have lost some mobility. You need a gentle but effective, deeper stretch. Okay, here's for children. Baxter, we're going to talk about tongue-tie stretching for children. This one's also on YouTube also. Children, it's 2 to 3 times a day for 4 weeks, starting the day after the procedure. Lift up the lip all the way up. Make sure you can see the whole triangle or diamond shape open up. and then massage right on there about 3 times. Pretty firm pressure, like you're massaging. Pretty firm. If you just lift a little bit, it won't work. Flip it all the way up. Okay, just like that. For the tongue, you're gonna hold the lower jaw with the non-dominant thumb. Use your index finger to push straight down in the floor of the mouth, then back all the way. If you don't lift it all the way up, it will stick back together. If you don't use enough pressure, it will stick back together. And that one was just done, so that's why it looked like that. But normally you'd have a white yellow scab. Here's a deeper stretch for a child. 1 week mark, or if symptoms come back, notice there's a T shape on there, like a horizontal line. That's where it's sticking back together. Push straight down, pretty good pressure, and it just opens right back up. There will be a little bit of bleeding, however, so keep that in mind. If you do need to use a tooth chair on maybe a 2-year-old or 3-year-old, just have them rest their teeth on there. And then you'll notice this one, it was sticking back together a little bit. There's a horizontal line again. So we're gonna push straight down and it will just pop back open because it's healed on top, but not below. So push straight down and then it's just open back up. So it's better to do that than having to laser it again. We don't want to laser it again if we don't have to. And so for teens and adults, again, 2 to 3. I'll skip the teens and adults parts, but anyway, if you don't do that deeper stretch, it will stick back and their speech will be better for like a week or 2 and then worse. Plus for toddlers, we give the parents, like a 1-year-old, 2-year-old, 4-year-old, we give them a tooth chair, a mouth prop to take home with them. It's in the, if you download the forms, it shows you which one to get. We get them on eBay, they're like $5, right? Don't give them your $200 mouth prop, okay? So follow up with all patients. In person is our preferred method, especially if you're just getting started in this. You want to see them in person almost always. Email if they're 3+ hours away, although we still have a lot of people come back from further. The farthest we've ever had was from Houston, Texas, is 11 hours for the follow-up visit. They drove back that far. Check for symptom improvement. That's the best time, though. Please don't skip the follow-up. It's so great. We don't charge for follow-ups, but that's when you could see like they're so happy most of the time and it's better. And we'll do the deeper stretch, which the baby doesn't like very much. You have to warn the parents there might be some bleeding. Make sure they've seen lactation. Make sure they've seen the PT or the chiropractor, the speech therapist. And then you can change your surgical technique based on your findings, right? Always offer compassionate care. So don't interrupt mom. Empathize, a gentle exam, gentle treatment, gentle follow-up. We're going to check the healing, do a stretch, but I'll be gentle, and then you are gentle. But make sure you're still doing enough pressure, of course. Consider offering a prayer before the procedure. We ask all the patients, hey, mom, is it okay if we pray first before we get started? And 99.9% of the time they say yes. Sometimes they're like, I'd rather not. That's okay. We always ask. Most people appreciate it. And in the Google reviews, they do mention that typically. They say like, hey, we really appreciated, and they got us in quick, and they were efficient, and they did a good job by like praying with me or the phone call afterward. They really appreciate that too. So call personally and check on them. Takes about 10 minutes for me to call everyone. People really appreciate that. Team answers the emails and phone calls promptly. They'll answer over lunch. We'll pay one person to answer phone calls over lunch. Try to run on time as much as you can. It's not always, but at least apologize if you are behind. We have a 10-15-minute video that we'll show. It's also on our YouTube channel, but I'll show that if we're behind or if we're running ahead, we can show it afterward. Try not to overschedule. Take time off, enjoy your life, exercise, meditate, pray. A couple of examples real fast, just a few case studies, and we're kind of running over, but here's some case studies briefly, and then we'll take time for questions. So there's a 4-year-old. These are, we had, I think 8 or 9 patients I put in just from this one patient, this one day, right, on January 26th of 24. So this patient had all these feeding issues and speech issues, early interventions, sleeping crazy, lip tie. And so not much there though. Look, they have a mountain of issues and it's not obvious, right? So we released it. 7 days later, eating more food the same night, talking better, he's sleeping better, doesn't move at all over the bed. Here's mom. These are real people, right? Real people.
For the procedure, we struggled with S words, L words, B and D, and since then he has been able to take his tongue and reach to the top of his mouth and make those L sounds better. While sleeping, we call it an H. My husband on one side, I'm on the other, and he's in the middle across from us. Since he's had the procedure, he sleeps in one spot, no moving other than to get up to use the restroom.
Eating any different too?
Yes. After his the first day, once we got back home, he ate pizza, chips, popsicles, chicken. He like over and over and over again. He's usually a very picky eater. So his eating habits have definitely improved.
Cool.
Hit to my grocery.
Yeah. Would you do it again?
Yes, absolutely. Absolutely, it's 100% we would do it again.
Perfect.
Justin?
And here's his tongue. It was not obvious, just that little bit. And there's the release afterward. These are real people. Same day. Here's an 8-year-old. Slow eating, constipation, sleeps restlessly, mouth open, issues as a baby that didn't improve, right? Gap between her 2 front teeth, mouth breathing during the day. Look how big, that's a pretty large gap. So we released the lip. Look at the tongue though. The tongue was pretty tight and no one picked it up as a baby. Mom had all these issues, asked her providers. She didn't get any help. Notice though, how much higher it lifts now. See the dorsal surface, the top of the tongue. Now you don't see any, goes all the way up. And then here's mom's story. This is cool.
7 days ago, she had a lot of difficulty with sleeping, very restless, was sleeping with her mouth open, wide open, head thrown back, having a little bit of issues with eating slowly. And ever since we had things released, she says that her stuffy nose cleared up immediately. She can breathe a lot better. She's sleeping with her mouth closed now. There's not so much mouth breathing during the day. And she even said that she can move better, and it's had really good results. Very little bit of pain just for immediately after the procedure, but really none since. Doing wonderful.
What do you think?
Well, I think that it's so hard to explain, but I can do everything a whole lot better. I can turn my head like this, and I can do this, and I can do this, and I can do this, and I can even do this.
Lift your tongue up now, perfect. Good. And then what else did you notice? When you left the office, what did you say about your nose?
Oh, I could breathe through my nose like the second I got in the car. I think it was like the best relief ever.
That's amazing. Thank you so much. And here's hers. There's the lip before and after. There's the tongue before, didn't lift up hardly, and now it goes all the way back. Perfect. So what's crazy is that lip tie, when we release that on adults, they'll often tell us, I can breathe through my nose better. When you release that fascia, it releases through here. Almost always they can breathe better through the nose. It's crazy. I would not have known that. And every adult tells us that we did the lip tie on. So anyway, same day. This is just right after that one. I did not know these people were coming, but I knew they were coming at some point. I know this. I was just taking videos of like all our follow-ups and stuff. So it's from January 26th. Tried 30 different brands of bottles. They saw a lactation consultant, a pediatric dentist admitted to the hospital, 9 different professionals, ENT. They had a pediatric dentist released it in Pretoria. Not sure where that is. We'll find out. Shallow latch, falls asleep in the middle of feeding, popping off the non-gagging, choking, coughing, hiccups. I don't have time to go through all these, but colicky, Nexium, won't take his bottles, snoring, like all the things, right? They're on the struggle bus. I says, how are you doing? I don't even know. I'm so depressed because of a lack of knowledge. So I'm so glad you guys are here to get the knowledge tonight, right? Here's what I saw when I looked in there. Pretty large lip tie and tongue tie. It was already treated, right? I think they did some stretches, but it grew back together. Okay, so it was not enough. Here's the cheeks. Before and after, we did the cheeks as well. Okay, here's a week later. Less reflux, deeper latch, less falling asleep, milk is out of mouth, less snoring, babbling, way more, raspberry squealing. And then mom's hopeful. Brother is also there. So this is brother. He's 4.5 years old. He wants his tongues fixed so his friends can understand him. He's so shy. Listen to that. All these issues, like this is a mountain of issues. This kid has a lot going on, right? Trouble with eating, and won't try new foods, constipation. They thought he had autism, but doesn't tick the boxes. Tripod sleeping is younger. He snores, grinds his teeth. They saw a dentist, pediatrician, ENT. They said he can stick his tongue out. Mom said, that's not the test. Dr. Baxter says that's the worst test. They said, who's Dr. Baxter? I thought that was funny. But 7 different providers, woke up like 8 times at night as a baby, all the things. He's already had tonsils out at 2 years old. He's really struggling, okay? His speech, he's on the age of a 2-year-old. But look, it's not obvious. They said there's nothing wrong with him. But look, see how tight. Now you guys know that lifts halfway. Which child is going to have a better chance at speech? His lip is fine, right? There's nothing to do there. His lip is fine. His palate's kind of narrow. Some expansion could be helpful. But his tongue, this is like low-hanging fruit. Let's treat that and see what happens. Took 10 seconds. We did not put him to sleep. 10 seconds. Here's the story.
Please, this is my friend Jaden. I've got a 5-month-old as well. Dr. Baxter just did Jaden's tongue tie released a few seconds ago. He's already speaking better after 2.5 years. Speech therapy, tonsils taken out, seeing ENTs, dentists, scratching consultants, a whole lot, and everyone showed me a way, tells me there's nothing wrong with my son. His speech is on an age of a 2-year-old. Seconds after Dr. Baxter did the procedure, he said thank you to the doctor, and he said it much better. I think we do have work. And then Baynant, which is 5 months old, had a deep snore. He couldn't keep his milk in. He drank now a little bit. No leaking on the corners. And he's not snoring at all. Seconds after the procedure. Awareness needs to be made. Thank you, Dr. Baxter. This is going to be life-changing, and I'll be forever be grateful.
Where are you from?
South Africa.
Did you hear that? They flew from South Africa. Mom is like determined to get help for these kids. Obviously, she read the book, heard about us, got visas for her children. She's never been to the States before. They're not like super rich, wealthy people. Flew over to get treatment for their kids. Unbelievable. Look at that. And so we have a map of the office. So you can put pins if doctors come visit or patients. They're from South Africa. We've had people from other countries before, like Japan and France and stuff. But that was super cool. It's a neat story. So anyway, and the very next day, this patient comes in. I was like, oh my gosh, this is like the craziest story too. Here's a 7-year-old. She has cerebral palsy. She has tetralogy of Fallot. At 6 months old, her left ventricle exploded. She has 53 minutes with no pulse, right? CPR, everything. She was on ECMO. They had a 1% chance of surviving a surgery. She survived. Another surgery, they said 1% chance of surviving. She survived. And then after that, she had all kinds of issues, a feeding tube, all the things, right? Small appetite, trouble gaining weight. And they said it's all because she has cerebral palsy and HIE. So they look in here. She has mild obstructive sleep apnea, but now we're treating it. She wakes up easily, like she can't breathe well, all these problems. Look in there. Her tongue is like pretty tight though. See, it can't lift up the, so that's afterward. There's her lip. We also did her cheeks were pretty tight, just trying to release some of that fascial tension. If CP, there's often a lot of tension. And so they came from Ohio. They were there the next day. And this is in January.
My name is Katie Robinson.
Or a few days later.
Robinson. We were just in today to see Dr. Baxter. It's January 31st. And my daughter was born and at 6 months had a massive cardiac arrest. And as a result, HIE, CP, all the labels came that followed. She, since then, after 6 months, has been suffering with severe reflux, constipation, this snorkeling, like she sounds like she has a cold all the time, on Zyrtec since for 7 years. She's 7 now. And we've done all sorts of therapies, flew down to Orlando. A therapist quickly identified she had multiple ties. And it's a feeding therapist. And she goes, she will do so well relieving this. Flew in from Orlando this morning to see Dr. Baxter in Alabama. He released the upper lip, the side cheeks, the tongue, and literally, when we were in the car, she was breathing again, not snorkeling, breathing comfortably. Her face looks so relaxed. She pooped, which is amazing because we've been on planes and trains and automobiles, and that would not happen. I mean, just the start of, I could see success. I'm so, so grateful. Where we've been bumping into walls, we can see hope. And praise God. Thank you, Dr. Baxter. And we will look forward to all the gains. Thank you.
This is why we treat tongue ties. This is why we do what we do. So rewarding. They wrote this the next day, I think February 1st. Thank you both for your God-given wisdom, care, expertise. My life was changed in 2 days because of you both. So Nancy, New Jersey, pediatric feeding. For 7 years, I've been told lies. As of today, 2/1/24, I can breathe, I can eat, I can drink, I do not throw up, I can poop, my hips are loose. I do not need to take medication for allergies because I don't have them. You don't have to take suppositories 'cause I can poop. The list goes on. Bless you both, your families, everyone that works with you, all those you help. So I was like, oh, this is unbelievable. And then I think a couple of days later, went to the American Laser Study Club conference in San Diego and got to share those stories. It was like, it just happened. It was nuts. So very briefly, like, what's your vision? Why are you looking to do this? What are you looking to do with your life? What's your why? You know, we all want to live for something bigger than ourselves. So for me, it's educating others, whether it's like the seminar or speaking. Here's speaking our girls Latin. I was subbing for Latin. I don't speak Latin. I speak Spanish, though. Close enough. Figured it out. But training others, and then our family, of course. Here's Molly. She was born 5 years ago. It was a difficult delivery. It was like 4 hours of pushing, like a lot after 5 days, going for a VBAC. We got it, but it was difficult. And she came out, she had a tongue tie to the tip. I was real proud of myself. I waited an entire 5 minutes before telling my wife Molly had a tongue tie. And then we went to the office and released it. But you notice these pictures look different. Had to take these with the phone because the power was out. The power is out, but I got a battery backup on the computer. I took the computer off, put the laser in, plugged it in, it worked. So everyone that has a light scalpel, you should definitely get, or any laser, you should get a battery backup or get a generator, but that's a little bit cheaper, the battery backup. And then she was mouth breathing before. Now her tongue is resting up on her palate. Then she gained a pound a week for 7 weeks. She gained a pound every week. And her sisters loved her. And now she's big. This is from a few weeks ago when it was cold. And there's no way she'd be singing like this, talking like this, thriving like this if her tongue was to the tip. There's no way.
You're the best, Daddy. Daddy, you're the best, Daddy. Daddy, so love me so.
Yeah, no way she could sing like that. She had a to the tip tongue tie. So there's Molly. And then briefly in October, went to Nepal. We did a dental training there. We trained pastors to extract teeth. So let me say that again. So we went and trained non-dentists to take teeth out. And it was in the middle of nowhere. So there's no dentists. There's no doctors either. There's also no lawyers. But it was cool. We trained them. In 1 week, they take out more teeth than the average dental student takes out in 4 years. Right? They all got a training certificate afterward. He said, Brother Richard, help us baptize this man in the river. He was a former gang member, had big stab wounds. We almost got swept away in this Himalayan river. It was very cold. They gave us some stuff afterward. It was super cool. And by the end of the week, they were doing all the work themselves. And so now I'm here in Alabama and they're over there in Nepal still training. With the training we gave them and the tools, and they sterilize them and everything, they're getting teeth out safely and effectively and helping their community. So it's cool just to train others in that way. So anyway, so how do you get started? Get trained. This lecture is not enough. Screen your existing patients. Start with an easy case, maybe during a general anesthesia case. You can use an electrosurge on 12 to 15 cut. Don't start with babies or toddlers. Choose a cooperative patient, maybe a lip tie first, and then do not do your team members or your family members first. Wait at least like 50 cases or you'll be sorry. They know where you live, right? Practice and then see everyone back for a follow-up and then adjust your technique, the stretches even more based on your findings. Team approach is always all the team members. I know we have a lot on the call tonight. Thank you for being there. We cannot do what we do if it was not for the team, right? If you just do the release, it'll work like, I don't know, half the time. But if you combine it with therapy and the body work and everything, it'll get even more and more and more successful. So last part. Takeaways. Proper assessment evaluation is critical. Ask them to lift the tongue, not just stick it out. Symptoms and function are more important than the appearance. Again, common does not mean normal. Screening should be conducted at hygiene and well child visits. We screen for all these things like hearing loss and PKU and SCID and like all these things in babies, and it's like 1 in 100,000, right? This is 1 in 4. Tongue tie is 1 in 4. The sooner it's addressed and the more team members, the better. You have to assess them, diagnose them, treat them, and follow up properly. It can change over time and can last a lifetime. They also place significant limitations on a patient and family's quality of life. So if you do want to download the forms, you can get those right here. If you want Tongue Tied Academy, I have a code for you guys. ALSC 24 is good for $400 off the full course. If you're a therapist, we have a lot of therapists enjoy the light course. It's 13 hours, $150 off with the code ALSC Light. All right. And with that, we have time for some questions. Let me see. Daniel, do you have the questions there? Okay, here we go.
Yep. Yeah,
All
they're
right.
in the Q&A box. Yeah,
Okay,
if
perfect.
anyone else has any more questions, feel free to ask them in the Q&A
Put them in.
box.
I'll hang on. I'll answer them all. It's like 9 o'clock here, but it's okay. I'll answer them. How do you evaluate function in an infant and preschooler? Any instruments? My experience is that even oral pathology have a specific instrument for speech. So in a infant and preschooler, the function is basically based on the symptoms, right? And so they're not going to lift the tongue up like we would expect an older child or an adult to do. I think that's what the question's getting at from Rosanna. And so we're going to lift up and challenge the tongue for them and approximate that function. But we're not expecting them to like go through oral exercises and stuff like that until they're at least like 5. But anyway, yeah, so it's based on the symptoms of the appearance and not as much like the function in that age group, but we kind of use like the symptoms for a proxy for function. So why do you do the stretches directly over the open wound? So thank you, Michelle, for the question. So a lot of people like say, don't touch the wound. But the problem is, though, you can't get enough tension on it. And the key is tension, whether you're doing the release or whether you're doing a braid, we have 3 girls at home, or whether you're doing stretches. And so you really have to write on it. It's not rubbing vigorously. You're just kind of stretching it out. Just like if you were trying to do like a stretch or like a massage on someone, like a workout, a knot or something, you just have to go up and down slowly, just like the videos show. Otherwise, we see it grows back together. How do we know? Because we get everyone back for follow-up and we try stretches one way, we try stretches another way for a week and see who looks better. More about the link to ADHD. Thank you, Jess. So if you are sleeping poorly, your tongue is held down, flopping back in your airway, get less oxygen to your brain, you get fragmented sleep, you're not getting high quality sleep. That can lead to you're scattered, like new parents especially. You can't focus on things, they're scattered, you get aggressive behavior. There's lots of studies on this, Miano 2018, sleep phenotypes. It's pretty well established that poor sleep leads to ADHD symptoms. Is the questionnaire used to screen patients validated? So our screening tools are not validated. You don't have to have a validated tool. For research, it's helpful. It says like, would you consider the Hazelbaker tool? That's not, the Hazelbaker is only for, I think, babies under 6 months old, Rebecca. And so lingual freedom protocol, I'm not sure when that one's validated, but I know Hazelbaker is not for kids or adults or even older babies. It's only validated in younger kids, but you don't have to do that. So it's more of the form we have is basically to have a conversation with the parent, look it over, and then it's all based on like the feel, how tight it is, where it is, and then I'm thinking risk versus benefit, right? So it's individualized, like risk-based assessment. Do I think for this individual child, if we release that tongue, we're going to get enough symptoms to at the end of the 4 weeks, they say it was worth, add up all the negatives or all the difficulties. So paying the money, they had to drive a far distance. We had to do the procedure, which is sore. The stretches are honestly the worst part. Worse than the money is the stretches, everyone says. So if you add all that up in the negative bucket, you look at the positives. Do I think we're getting enough positives that's worth it for this individual child? And most of the time, I'd say like 95% of the time, we're getting people say like, absolutely, I would 100% do it again. Sometimes we're like, yeah, it was okay. Like maybe I do it again. Sometimes, very rarely, it says unsure, and almost never do they say, no, I wish I hadn't done it, right? So it's working pretty well for what we're doing it for, but it's not validated. Do 2-year-olds need exercises pre-releases? Jessica asked that. No, it's not necessary for 2-year-olds to have exercises like myofunctional exercises. Some people can do like baby myo. Typically, traditional myofunctional therapy is going to be age 4 and up. And you can do oral motor therapy with speech therapists. That's a different thing. Of course, it's helpful the more therapy they have, but I'm not going to like not treat someone because they didn't do myo on a 2-year-old. What's the youngest age you were released? 1 day old. We've had a couple of 1-day-olds. We have a lot of 2-day-olds, 3-day-olds. But yeah, 1 day old. As soon as they come see us, it's safe. If they're out of the hospital, it's safe. We've done 4-pound babies that are several weeks premature, that kind of stuff as well. Tracy said, we have a client independently lift their tongue. Do they aim for the alveolar ridge? So have them lift the tongue up and it's touching the spot. It's the incisal papilla right behind the central incisors. Carly said, do you recommend myofunctional therapy before and after the release? So we require it for 13 and up because we had to have a hard cutoff. Almost all of our patients, though, that are 7 years old or 10 years old, have a speech therapist. There's only one myofunctional therapist in our whole state. So we have a list of lots of virtual therapists and recommend those. It's an expense. Myofunctional therapy can be several $1,000s on patients. A lot of our patients are on Medicaid. They don't have much money. And so they can barely afford the release and then like their school-based speech therapy. So we do the best we can with what we have and making the best judgment, but it's individualized. But of course, I wish everyone had myo. What are your thoughts about creating scar tissue if you remove the frenum for eruption 8 and 9? I mentioned that during it before. I think there's no scar tissue if you do it this way, right? If you're releasing it this way, getting it all the way down, the gap closes up 94.5% of the time. There's no scar tissue. Any experience with erbium laser on soft tissue? So if you use erbium, you will get less charring of the question. So what the question said, less charring of the tissue. With CO2, it also has less charring. With diode, you have more. Scissors, there's none, obviously. Brianna said, a few questions about billing. Pediatric dentists, we don't have time to go into all this, obviously. Bill separately, consider medical procedure. Complicated. People insist we try to bill dental. So we don't bill dental, but basically give them a super bill. We give them the claim form. Questions about the entity. So if you have a tongue tie entity, that's helpful. So we have the Alabama Tongue Tie Center. So all of the procedures are all billed out through tongue ties. So they're not going through the dental office. So that helps a lot. Medical insurance reimburses most of the patients, not all. Dental insurance, the problem with billing dental, though, if you bill dental, then they can come back at any point and take that money back, right? And so then you're in trouble because now you've done the procedure and you billed it to dental. They may have paid you, so you gave a refund to the patient. And now dental comes back, Delta, whoever comes back asking you for the money, you have to give them the money back or they'll just take it out of your account if they have direct deposit. And then you can't go back to the patient and say, oh, like I need the money back now. So now you've just done the procedure for free. So we used to do it that way. I promise you the best way we found is you bill the patient up front, they pay up front for it. They know they're not going to ever pay any more than that. And then there's no surprise bills. Here's a claim form, send it off for a possible reimbursement. Now it's between them and the insurance company. All right. What's treatment for reattachment? So a deeper stretch, like I showed, deeper stretch, you can do it for about a month or even 2 months after the procedure. You can still do a deeper stretch. Much after that, you're gonna have to re-laser it again to retreat it. And that's only if symptoms come back. So if just a string is back, but symptoms are better, you wouldn't treat it again. You're only gonna revise it or a second or third procedure if it's stuck back together and symptoms got worse after they got better. Question about topical. Again, this is like a 1 hour cut, so I can't go into all the things, but worry about methemoglobinemia. That's always a good question. In the Tongue Tied Academy update, I go through all those questions, like basically all the questions you guys are asking here, sutures, like methemoglobinemia, vitamin K, all the things we go into that in detail in the update. So methemoglobinemia with 2% viscous lidocaine, a tiny dab, I'm not worried about it. The risk is infinitesimally small. It's definitely a risk. It's still there. Higher with benzocaine, higher if I used a compounded topical, which we don't use. We're just using only lidocaine. Very, very minimal risk. Never seen it. And we've done it 10,000 times, over 10,000. I don't even know how many at this point. What is the reasoning for treating babies away from parents? I only refer to dentists who allow parents to be present. So Jill asked that. That's a good question. And so like Dr. Kotlow says, he's the kind of where I got this from, but and Harry doesn't do it, no parents in there. If a parent really wants to be in there, they can come in. So like you can refer to us, Jill. We allow parents to be present if they want to. But for the postpartum mom who's emotional and trying to nurse, if they're nursing the baby and they're super stressed out and they see that, I've heard that it can shut off the milk ejection reflex. And so they're less likely to be able to nurse as easily afterward. The baby's not going to remember. The mom, if they watch it, they will remember. We don't want that. We're going to borrow them. It's so quick. It's literally 3 or 4 minutes. I tell them 5 minutes, but it's like 3 or 4 minutes they're away. But if dad wants to come back and sit in the chair in the corner, we have dad come back all the time. But most people wish they hadn't seen it. All right. Do you recommend sutures? If so, at what age do you suture? So sutures typically like 10, 11 years old. If they're cooperative and up, we'll suture. If I have a patient asleep for a dental rehabilitation, so I'm not putting them to sleep for a tongue tie, but I'm putting them to sleep to fix like 15 cavities and they need a tongue tie, I'll suture then. And then adults, we suture. So hopefully that makes sense. Tell the difference in your in-person versus online course. So online course is 25 hours. It's the A to Z of tongue tie. It can take someone who knows absolutely nothing about tongue ties, and then you're like ready to treat. Has virtual shadowing at the end, so it feels like you're there. A lot of people still like want to see it, feel it, ask all their personal questions. Like these things, show me cases. That's for the live, the advanced live patient course. Or if you do the online and then you treat for maybe a few months, and it's like get some cases under your belt and then come see us, you'll learn more that way. We have the update course. So the new sequence of events would be the full Tongue Tied Academy, then the update course to like give the latest protocols, and then come see us. And then next question, all the videos are on YouTube. Yes, just search Alabama Tongue Tie Center. We have a channel. What are some complications cutting the salivary ducts? So if you cut into the salivary ducts, you may have to recannulize the salivary ducts, which would be really bad and complicated surgery. We've never seen that happen. The patient that they did cut the salivary ducts, they were okay. They did not have to have that surgery done, but it's a possibility. You can get a ranula, you can get mucocele, all kinds of other issues. Topical medication for a 10 to 15-year-old post-procedure. So we've tried that, Stacy. We have tried using topical afterward, like for the stretches. I wish it worked. It doesn't work though. It just makes them more numb. For a baby, it would increase the risk of methemoglobinemia, of course. We wouldn't want that. For a 10-year-old, you could certainly try it. Ice would work similarly. The stretch is just, it's that pressure. Like when you take a tooth out, you can't take away the pressure. When you have a baby, you get an epidural, can't take away the pressure, you can take away the pain. So even with the topical, you can't take away the pressure. It's sore. Have access to the symptom list and the procedure list. So if you use that QR code right there for the forms, or our website, tonguetieal.com/professionals, you can have the access to the symptom list and all our consent forms, everything. Danielle says, precious children, keep up the great work. Thanks so much for sharing your work. Feeding therapists and a lot of babies and children your way. Oh, that's nice. Okay, thank you. Lori said, great lecture, thanks. If you do same-day releases, do you not require pre-frenectomy myo? So the majority of our patients are like toddler age, 2, 3 years old, or they're babies. We have some maybe 10, 20% school age, and then like adults and teens might be 5 or 10%. It's might have like one adult or teen a day. And so we require myo for them. For the 6 to 8-year-olds, they almost always have a speech therapist they're working with. We recommend everyone do body work. We do the best we can with the area we're in. We're in Alabama, not saying Alabama's backward, but we don't have the resources. Like if I was in New York or in Dallas, Texas, or I was in Los Angeles, we could do a little bit differently. But a lot of our patients are coming from middle of nowhere, Alabama. And you say myofunctional therapy, they have no clue what that is. We educate them on the phone, try to tell them, but anyway, we do the best we can. So we don't have people come see us for an adult or a teen until they have a letter from their myofunctional therapist saying that they've done all their pre-work and they're ready that day. So, okay, compounded topical for 12 months and up. Adriana, 12 months and up, we use compounded topical, Lido, Prilo, tetracaine with phenylephrine. Tessa said, you know, SLPs that are trained to release. SLPs, it's not in your scope of practice, so you cannot release as an SLP. You definitely cannot do a release, so please do not do that. Don't hear me say that. Also, like even like stretching and like wound care on patients, that's like a gray area. Be careful with that. Talk to Robin Walsh about scope of practice. Bryn said, you answered my question. Michael said, thoughts on having parents of baby in the room. So back to Dr. Kotlow says, he said, suppose, like, what are you going to gain out of being in the room? So if the parent's there, suppose there is a problem. Suppose there is an airway issue with the baby, or if mom is standing there or dad's standing there, we've had parents almost pass out on us. Now I can't focus on the baby. I'm having to deal with dad passing out or mom having to like sit down, having to get some ice water for her because she's about to pass out. So that's why Dr. Kotlow says it's like you don't have that at the operating room. It's like a mini hospital at our office. We're not having, you know, if you go to Children's Hospital, you can't, there's a red line, you can't go into the operating room. Same kind of thing. They would never let a mom watch them like intubate their child, because if there was a problem, they want to focus on the baby and not have a problem. So if there is a problem, we need to focus on the baby, and we have all the PALS training, ACLS training, all the trainings. We can take care of that baby. But if mom's there or dad's there in the way, if God forbid something were to happen, never happened, but if there was more bleeding, we need to get that under control and not have mom freaking out and like try to snatch the baby away or something. So hopefully that makes sense. Thank you, Michael. But if dad wants to come in and sit in the corner, we have him back. Now for 12 months up, 12 months and up, we invite the parents back. So if it's like an 11-month-old, we'll say, hey, mom, come back with us. If they have stranger danger, it's an 8-month-old, of course, we'll have the parents back. We're very reasonable. We never tell people they can't come back. We just highly recommend they don't come back if it's like a newborn. All right. My local provider will be doing my almost 6-year-old soon. He does sutures on the tongue lip ties that necessary for her age group. So it's helpful if they can get sutures on a 6-year-old. It is helpful. I don't think it's necessary to suture babies. They might put one stitch in, but like on a 6-year-old, it depends on how cooperative they are. If he's freaking out and not letting you get in there, then it's not worth doing sutures. If he's super calm and chill and you can get a couple in there, sure, it's helpful. But then they're probably going to bill out a frenuloplasty, which is like twice the price of a frenectomy code. So often it's more expensive. Gabriela said, how do you evaluate the need to suture after the release? Saludos de Mexico. So she's from Mexico. Gabrielle, look at Instagram for Dr. Eric Pediatra. He's a pediatrician in Guadalajara, Mexico, and he treats tongue ties. He came for our live course. He is like Dr. Tongue Tie in Mexico. So check out his Instagram. He has like 100-something thousand followers. But anyway, how do you evaluate the need to suture after the release? And so basically, I think I answered already, but teens and adults we suture, cooperative older kids we suture, dental rehabs, if I have them asleep already, we'll suture. Deeper stretch for older kids at week 2. I deeper stretch everyone. I'm just going to do it. It's not, deeper stretch is a misnomer. It's a normal stretch. I say deeper so that the parents don't feel bad and feel like they didn't do it right. So I'm going to push pretty firm on there and just do like a normal stretch, but it's often harder than they've been pushing and it opens back up. So that's why I call it a deeper stretch. Now you know my secrets. I've been told in Australia, all babies are screened at birth for tongue ties. I don't think they are in Australia. In Brazil, they are. In Brazil, they're screened at birth for tongue ties. I don't think in Australia they are. In America, they're not. I wish they were. Even in Brazil, though, it's a national law. They're not checking appropriately. It's not all. They're not all trained to check right. So it's a good idea in theory, but it's not like a blood test where you're like, oh, you have PKU. Like you got to, avoid Diet Coke, like that kind of stuff. It's not to that degree because it's a spectrum. So some babies that would be checked at hospital, they say, oh, no tongue tie. And then they'd have all these issues later on because it was a less obvious posterior tongue tie. So in that respect, it might actually make it worse that they've screened as a baby, right? And so what needs to be said is, hey, mom, if you have issues nursing or bottle feeding, like come back and see us, come see lactation, let us know. There could be something with the tongue that we can help fix, right? So anyway, Danielle said, do you recommend teaching parents the stretches prior to the release? So we show them afterward because beforehand, it's like a little bit too crazy. And if their tongue's to the tip, you can't actually do the stretch beforehand. So we show them afterward. I'm glad you guys show them what it looks like so they can be mentally prepared. That is helpful for sure. Thank you, Danielle, for what you do. Lori, do you place sutures for kids if they're awake? I answered that one. Jody, how do you suggest getting the stretches done on those in the age group of 18 to 2.5 years? So if they're 18 months old to 2.5 years old, typically what happens is people just don't even treat that age. Honestly, like 9 months old, 6 months old to 4 years old, I call it no man's land. People just don't even treat it. I think because they didn't have a good way to get in there do the stretches. And I agree. If you can't wear the earring, you shouldn't get your ear pierced, right? So don't do the procedure if you don't have a way for them to get stretches. But the game changer is the mouth prop. If you can, one of the dads said, hey, if I had that, I could do it. I said, here, take it. He did it and he did it great. Show them how to use the Molt mouth prop. Make sure it's resting on the teeth. They can do the stretches really well with that. They can get in there once a day minimum. Shoot for twice a day, once in the morning, once at night. Typically the first week or two, it's sore. They're not going to like it. After that, the second, third, fourth week, it's not as sore. They're just mad. No screen time until you do your stretch. Give them an M&M, a little prize, something like that, right? Do you ever postpone treatment in spite of need due to parental distress or postpartum depression, postpartum anxiety, but then reevaluate at a later time? How would you communicate that? It's a really good question, Shannon. Had one mom yesterday. She was really stressed about it, real nervous. She scored a 12 on the EPDS, 12 or 13. So she has it. She's on medicine already, she said, but she's really struggling. They are colicky, spitting up, gassy. There's no pain though. And her previous child had pain. And she's like, I just can't do this. I don't think they have a tongue tie. How do you know? I said, well, it's almost to the tip. That's how I know. And plus they have all the symptoms. It doesn't have to hurt. Explain all that to her. Say, well, the pediatrician said there's nothing there. And another pediatrician at the hospital said there's nothing there. And then lactation said there was just a little bit. I said, well, it's almost to the tip in the picture you can see. So just really gently guiding it. But you guys are fairly close by. If you want to wait till another day, think about it, come back and see us. And then I'll just walk out, let them think about it. We'll watch the video. It's 10, 15 minutes. Anna goes in, talks to her. She talks to Anna. She's like, yeah, I just want to do it today. And so what's interesting is though, 1 week later, almost always, I need to do a study on this. Maybe we will. That'll be the next one. But almost always at 1 week, they check the form that says, on the form says, feeling more confident in a better emotional state. And the EPDS score goes from like 13 to like 5. So it's not all better, but what we've done is we've taken some rocks out of their backpack, right? It's like, it's like a little bit less weight off their shoulders, right? All right, Ashley, when evaluating infant, holding the chin down to open wide, should entire tongue lift up to palate. So on the baby, we're not like holding the chin down necessarily, but yeah, you can hold the chin down. You should lift it up easily to the palate. So it should easily flip up to the palate. Also check back and forth, side to side. That's very helpful. How does a high palate affect this? So often, chicken and the egg. I think what happens in utero is the tongue held down. The tongue is like a scaffold or like molding for the palate. So it helps it to have a nice broad palate. If it's more of like a bubble palate, they call it U-shaped or a V-shaped palate, high arch palate. What happens is it's probably from them sucking their thumb in utero because the tongue is supposed to rest on the palate, stimulating the nasopalatine nerve. My daughter Molly, I don't have a study on this, but like every time we saw in the ultrasound, she was sucking her thumb. And then when she came out, her hand was stuck next to her head in the birth canal. I think she got stuck in the birth canal sucking her thumb, right? And her palate's pretty high. So I think the low tongue posture leads to more in utero thumb sucking, leads to also there's no pressure on the palate, the cheek pressure predominates. I think that's what happens. SLP doing myo, getting a lot of pushback from ENTs. They don't need to release anymore because they are now functional. How do I get ENTs, other providers to understand we have done the myo, they're ready? Send them to us, Sarah, we'll take care of them. Say that tongue in cheek. Just find a good provider that understands the need for it. There's not many ENTs that are on board with doing tongue tie releases. I don't think it doesn't pay very well versus like a sinus surgery or something. Like tonsils and adenoids don't pay well. They don't reimburse well. They just don't. And so finding a dentist that does it well is a good thing. We do have patients from around the country though, so happy to take care if you can't find anyone they want to travel. Is there an age limit to adults? No age limit. Oldest we've done is about 70 years old. Youngest is 1 day old. That's a good question. Apply topical before the stretching. We talked about that already, but no, it doesn't really work that well. Do you recommend or require body work, chiro-CO2s? So we highly recommend it. We tell them on the phone, in the email we tell them, tell everyone to do body work beforehand. We get better outcomes with body work. Again, a lot of people from middle of nowhere, Alabama, they may or may not even have a chiropractor in their town. So we do the best we can. Thank you for mentioning symptoms being a primary indicator. Have you seen tongue ties being released early on in the infant's life, but then seeing excessive oral confusion months later? Haven't really seen that. If it's done properly with the right stretches, we almost never see like an oral aversion or anything like that. But oral confusion, if they haven't done like suck training, that's helpful. I see oral confusion with infants very often contribute to a tongue tie. This is the question that needs to have oral therapy prior to and post-release. So obviously it's very helpful too. Most IBCLCs are not on this course. They're not as trained as you, Rendina. So do the best you can. I know there's like IBCLC masterclass. There's all kinds of courses and like a million different stretches and sucking exercises. That's super helpful. If we can, if every baby had that, it would make my life a lot easier. So keep up the good work. But all the babies we see, I can't like make that a requirement to do oral exercises prior to and post, but I'm sure it works better for sure. What do you recommend for the large tongue in comparison to jaws in infants? Seems to enlarge quite often. So we haven't seen any like macroglossia. The concern would be like with Down syndrome possibly, but we've treated patients with Downs before, not had an issue. It's a relative macroglossia, I guess, if the tongue is larger, but when you release the tongue, it doesn't flop back like you think. It actually goes up on the palate and suction cups up to the palate. So any recommendations for therapists when encountering pediatric dentists not providing post-op care or resources, and then poor patient outcomes? Send them this lecture. We're going to put it on our YouTube channel. I think American Laser Study Club is going to put it up as well. So it's super helpful just getting this like latest information. A lot of people don't have the latest information. So like the Tongue Tie Academy update's helpful. But yeah, you have to do post-op care. If you just do a tongue tie release and then no post-op care, you're not going to get good outcomes. And then so I guess don't refer to them would be the easy answer. But it's hard when people have seen them and then come to you as a therapist. So that's hard. Tracy, how long do you have access to the course once it's purchased? As long as the course is up, we have it at least a minimum of 3 years, but Tongue Tied Academy has been out for 4 years already, and it's going to continue being out. Nothing in it's outdated or old. We just changed some stuff. So nothing's wrong, but it's unlimited access to it. It doesn't expire. Do you see good results without sutures under 10? We see excellent results even without suturing under 10 years old. So if they do high quality stretches, it will work well. Do you have an IBCLC on staff? We did at first, her name is Heidi. Then she realized she could do home visits and spend hours with the patients, and she actually got reimbursed better through Lactation Network versus in the clinic. She couldn't bill it as well. So she sees patients. And then now we're so busy, we don't have room for that. It's pretty small. We have 5 consult rooms, but we're using them all the time. So it wouldn't really work out to do that, but I wish it would. If I had my way, I'd build the world's largest tongue tie center and have like lactation, chiro, CST, like all the things there. But we don't have room for that. Ivy, have you had healing occur where extra tissue forms like a double tongue appears? So what happens is when you're stretching, sometimes you can get a granuloma or it looks like a second tongue appear. Often you can try to wipe it off with a 2x2 gauze. Sometimes you have to go in and laser it again. Often if you just leave it alone, it will go down and the inflammation will decrease on its own. Jill said, my parents want to be there to protect and support baby's nervous system. Never had a client regret being there. So like I said, they're welcome to come back. Never seen an issue with milk ejection reflex. Respect your expertise and all this. Strongly advise reconsidering decision to keep parents out by default. So we tell the parents if they want to come back. If people really want to, they can. I will definitely take that into consideration, Jill. Thank you for that. We always try to do what's best for everyone, and we offer parents to come back if they want to, but we recommend them not to. But I'll consider it. We'll try it and see. I'm definitely open to it. Thank you, Jill. I appreciate that. All right, Ashley, enjoy the presentation. Have my lactation patients here in North Carolina view the release videos. I'll be at ICAP. We'll be there. Excited for ICAP in just a few weeks here. Catherine, do you ever stretch with sutures in place? So wait till the sutures fall out. Typically, it's like 3-ish, 5 days when they're falling out, and then you're going to start the stretches. So that's the nice thing about sutures. You can wait a few days to start stretches. The most sore time is that first few days, so you can kind of get past that and then start stretching. Do you think doing the release with water lace, biolace would result in safer, more predictable results? So the water lace or biolace is an erbium laser. Often it's shooting water, so then the baby can kind of choke. You got to suction that up. The problem with the erbium is it does not coagulate nearly as well. It also, the tissue looks more raggedy when I've seen releases from people that sent them to me from water lace. And so the CO2 laser really does have the best of hemostasis, thermal, the cutting efficiency, and then the minimal thermal damage. So the erbium, what it does not have that CO2 does have is the coagulation is way better. It's a 10, I think it's 10 times better coagulation is the figure based on 10,600 nanometer wavelength versus the 3,000 nanometer wavelength of the laser. Do you release tongue to have a child whose adenoids are enlarged, nasal breathing is difficult? We've done that. We've done that fairly often. The adenoids can shrink. We don't say that they will. Now, if it's totally blocked, they're not going to shrink. But we've seen them go from mouth breathing to nasal breathing afterward. When you release that lip tie, it releases the fascia. They can often breathe better. So that's cool. A few more questions here. We've gotten 75 answered. It's like a lightning round. Thank you for sticking with us. There's almost 200 people still on there. Any experience with Photona laser? I have not used the Photona. I'm not sure if you're referring to the Light Walker or the baby lace. I've seen the baby lace. I had it done on my hand. Beforehand, it just kind of feels like a warming. It's supposed to kind of like warm up the collagen. I don't know of any like data on it. Some people have some anecdotal data on it, but I think that's what the question is there. An ENT told me it's a fad to make breastfeeding moms feel better. We hear that a lot. People say it's a fad, it doesn't need to be done, it's overdone, it's just like a social media diagnosis, Dr. Google. I told him we would not be cutting my child, found my own pediatric dentist to laser my twins, shaking my head, SMH, much longer story. Thank you, Tiara, for sharing it. I'm glad you're on here. It's not a fad. Yeah, advocate for your children. It's a long story. Our girls, I don't have time to share it, but they were clipped by the pediatrician. We thought it was done. We didn't realize it wasn't done all the way. And then we had to go see a dentist after lactation said, you need to go get this treated by a dentist who does it the right way. What IBCLC masterclass do you recommend? If you just type in IBCLC masterclass, it pulls up, I think it's Lisa Leahy. I think Kathy Watson, Jenna, I think Jennifer Tao. I think there's like 6 of them that did it. Midwives can perform frenectomy with laser, correct? It depends on your state, like in Arizona, I think, or Washington state, they can. In Alabama, they cannot. So it depends on your state. Practice Act. We check based on where you are. Are you interested in translating a book into Hindi? Let me check on Kindle. So the hard part is getting it published. So if you want to translate into Hindi, send me an email. It's info@tonguetieal.com right there. Send me a message and definitely we'll look at getting a Hindi version. I'd love to have a Hindi. I think that'd be very helpful. And yeah, that'd be super cool. So thank you, Jatinder. I'd love to see that if you know how to do it. So, and that was 82 questions, Daniel. Thank you.
Wow, that was a great presentation. Lots of questions, a lot of
Yeah, that's good though.
information.
That's great.
Yeah. So thank you
So-
everyone for sticking around to the end, and thank you, Dr. Baxter. That was really great.
Awesome. Thanks, guys, for hanging on. Good night, everyone.